outlook of nursing and midwifery practice in Ghana. What we have now and what the future holds. So I just want to invite the panelists to introduce themselves, just brief introduction, and probably just something small or the lens through which we are looking at the main theme. So we'll start with our own president, Mrs. Perpetua Ofori. Ampofo.
Hello everyone, good afternoon. I hope you had a good lunch. Okay, great. Western region, please get your people in. Northern region, get your people in. The empty seats are too many. Volta behind you. Get your people to come inside. So, I'm happy to be part of the panelists, and the future of nursing in Ghana, I think, is great.
Okay.
Opportunities abound for professional development, for career enhancement, diversity in terms of the path you may want to choose. We have the human resource in terms of future leadership. And we just need to probably look at digitization, AI, and how we can factor in all the current trends that are out there and how it affects our profession and how we can build our resilience around it or empower ourselves for the future. So those will be my initial comments.
Thank you very much. Please, we'll move to the next person. Just 1 minute introduction, and then tell us what you want to see in the nursing profession.
Thank you very much. Good afternoon, everyone. And greetings from the Rector and the Governing Council of the Ghana College of Nurses and Midwives. And the Rector is supposed to be here with us. Unfortunately, she has to attend to some other important issues outside the jurisdiction, so I'm here in their stead. And so we as a college are poised in ensuring that the outlook of nursing in Ghana drastically changes, because we cannot be doing the same thing and be expecting the same results. And we believe that specialization is the way to go. And so college is poised and positioned to ensure that cadres that are coming out are prepared to face the challenges that the health system is giving us. And so just a remark I want to give from the beginning.
Thank you.
Thank you, moderator. And my name is Mrs. Hefzibajima, as introduced earlier. I also stand instead of the registrar who would have wished to be here, but as it stands now, they are going around the country for inducting the newly qualified nurses and midwives into our profession. So she couldn't make it, and so I'm here to represent her. The future of nursing and midwifery, at the regulatory point of view, is so bright. There are a lot of opportunities out there, nationally and internationally, but what we looking at that we can embrace as nurses and midwives is to engage in economic decision makings. It's about time we come out of the status quo and begin to engage in policy decisions, engaging in copious research. This morning I was so happy when the first panel delved much into research issues. And I think it's about time we begin to embrace research, because we sit on a lot of data as nurses and midwives. And we give those data out, people pick them, they modernize it a little, and they put their names on it, and they begin to boast around. You can use those data and inform decision and practice so that we can see nursing grow properly. We should also be able to, I said, influence decision making through policies. It should not just be like 1 minute. All right, so let me just end this here. Thank you. Because, Madam Chair, the atmosphere was charged already before we left for a lunch break. And I wouldn't know if you want to give me the opportunity to start responding before we go on to other matters, because
I think Madam Chair mentioned earlier that NMC is here, so probably we'll give you a minute or two.
I'm grateful.
To address it before
I'm
we
very
go.
grateful. So I'm grateful. Yes, Mr. Jefferson Asari made mention that the regulator is the problem here, and that we are rather engaged in corruption issues. Alleged, thank you very much, alleged. Alleged. You know, sitting at a small corner, we also hear some of these things. And calls come in. There has been this corruption issue here. And we call for evidence. And nobody is able to provide that evidence. We have the mandatory or the mandate to regulate the nursing training and practice. But we cannot do this in isolation. You should be part of the regulatory process by ensuring that you carry out the regulatory requirements that are required of you to be able to be given a service that is required. And so if you go behind the scene to engage other supporting staffs that we have employed to help us, you know, meet our mandates, and they charge you at their own or whatever, if you are able to give us the evidence, we will be able to take the necessary actions against them. Quite recently, don't forget, I am also a GRNA member. Let me make that one very clear. Yes, I am a member. Madam President, I am a very strong member. Yes. You know, so one of us placed a call to the council and said, this person in the council has been extorting money from clients. And he was, even if, honestly, if I should have the name of the person here, I would have applauded the person, because those are the whistle blowing that we did to make our nursing go strong.
Thank you.
And so the moment he placed the call, we did our investigation, and it was true. And as I speak now, that colleague or that person has been dismissed from the council. So you want to be bold enough to bring out those corporates, and together we can expel them out of our system so that we can have a strong nursing force in this nation. Secondly, the delay of certificates. Certificates, we intentionally delay certificates because you are expected, or the student nurse or the rotation nurse is expected to go through 52 weeks of rotation. And some of them want to cut corners. So they'll go and pay their way out to, for them to endorse some of the areas for them, like the mental health nursing they don't want to do, so they'll go and pay their way through. And as regulators, we cannot sit down and let those things go on. So we ensure that they go through the 52 weeks mandatory rotation national service before we issue out their certificates for them. So it isn't that we are sitting down, we don't know what we should do as regulators, and some of these issues that you raise, it isn't that we don't hear them, we hear them, but bring evidence. Bring evidence, then we can act on the evidence to act. With this little explanation, I believe, Mr. Jefferson, are you okay? I believe that with this little explanation, You would. I know you'll not be okay, but at the end of the day, you'll be okay.
Okay. Thank you very much. So let's all try, and then the people that we have within us who are doing that, let's report so that we can get them out. Okay, to the next panelist.
Right, so good afternoon, everyone. My name is Evelyn Amwako. I am a Deputy Director of Nursing Services, and I work with the Nursing and Midwifery Directorate of the Ministry of Health. And so just to reiterate that there is a Nursing and Midwifery Directorate and at the Ministry of Health. I think somebody mentioned earlier that there should be advocacy for the setting up of such a directorate. So I want to reiterate that there is one already there at the Ministry of Health. Now to the main point, my approach to looking at the future, or the lens in which I look at the future of nursing and midwifery in Ghana, is one of system strengthening, guided by the Nursing and Midwifery Strategic Plan and Services Framework for Ghana. As we are all aware, and I'm sure, I hope we are aware, that there is a Nursing and Midwifery Strategic Plan for Ghana which was launched in 2024 with 7 pillars. We have 7 thematic areas: jobs, education, service delivery, data governance, research and innovation, partnerships and collaborations. And I'm sure we all realize that all of these have an influence on the future of nursing and midwifery practice. These interventions, the interventions under these thematic areas were developed collaboratively with all stakeholders in nursing and midwifery in Ghana. And so we had regulation, we had the union, that is the association, represented, we had service delivery represented, we had policymakers. And so all of us came together to develop the interventions for the thematic areas in the strategic plan. And so we have a clear roadmap ahead of us. But what is now important is the implementation. And so for us, the future that we see is all of us seeing ourselves in the strategic plan, in the implementation of the strategic plan, to enable us achieve the targets and the outcomes that we have set across. And so irrespective of wherever we are, we see ourselves and then help in the implementation of the strategic plan. The last health labor market analysis put nursing and midwifery professionals at 50, I think a little above 50%, and the nurse associates, the auxiliary, something above 32.3 or so %. And so when you put the two together, every time we say we are the majority, but we need to know the numbers so that we know what the majority means. The majority is above 80% of the total healthcare workforce that we have in Ghana. And so we are strategically positioned to influence the health systems once we put ourselves to it, and that is what I'll say. Thank you.
Thank you very much.
Good afternoon, Madam Chair, ladies and gentlemen. I'm Margaret Mary Alakok, immediate past president of COHETI, and I'm happy to be part of this program. I'm also a member of the Ghana Registered Nurses and Midwives Association. COHETI, as you know, the health training institutions coming together, of which nurse and midwifery training institutions are majority. We are the implementers of all the good things that have been said, the policies, the strategic plan. We are to implement it. And casting our minds back to where we all came from, each of us in this room, nurses and midwives, we've gone through either an NTC or a university. We started with the enrolled nursing, and then we have the health assistant ward aides. We came to the QRN. Then we came to the SRN, where one had to do some service before you can go into do midwifery, public health, and others. While this were going on, we also had the university education. Then we also transitioned into a diploma level, where you had a diploma nurses. Then came midwifery, diploma midwifery, where there were so many issues about them, but because it came in to solve a problem. And we are at this level. We now have the Ghana College also coming in with a specialization. We have terminal degrees in nursing and midwifery. If we move all along from enrolled nursing up to this where I've reached, we are still training certificate nurses, diploma nurses. So looking forward, what we as Cohete would like to see is for all the stakeholders that are seated up here. I think it's only the Ghana Health Service nursing director that is not here. We want to put our heads together and see how we can have the entry point of nursing and midwifery as degree to do away with the certificate training. These things have been discussed severally at several fora, but it's not the implementation. How do we walk this talk? I'm excited we have the key stakeholders here, and this delegates conference is a major decision-making body that will have it in a communique that we can speak to the stakeholders to implement what we already have. We should stop the talk and work it. So we want to see a polyvalent nurse, specialization, but not a crash program, specialized nurses that will match up to international standards. So when our products go out there, they don't have to stop nursing and do other things. So these are my initial comments. Thank you.
Thank you very much. Now, I just want to start with you. We are moving to the main question. I'm interested in what you said. So to begin with all the things you have just spoken about, what is the single biggest challenge affecting the future of nursing and midwifery practice and education in Ghana today?
The single biggest challenge is our decision to move ahead. We have all the good plans, but how to implement them?
Okay.
We have the strategic plan coming from the Ministry of Health, maybe other things coming from the Nursing and Midwifery Council, from the Ghana Health Service. We have a lot of documents that we can implement. But our biggest challenge is we do not have an act that mandates the training institutions to stand on their own in most of the activities. If you get to the Ministry of Health now, we don't have a nurse or an allied health professional that is overseeing the activities of the nurse and midwifery training colleges. You have a professional sitting there, you'll be able to understand our issues and implement what we really want to do. And another issue has to do with the infrastructure. When it gets to accreditation, the main challenge is that you don't have the faculty, you don't have the needed infrastructure. Who is supposed to provide this infrastructure? It's not the principals. The schools belong to the Ministry of Health. So the ministry is supposed to make sure that we have the needed classrooms, smart classrooms, you have a skills acquisition laboratories. I always keep mention of the one at UHAS, along they have a specialized one there. What prevents the Ministry of Health from setting up specialized skills lab for all the 83 plus nursing training institutions that we have? If you want to depend on the principals, go and set up your own school. Accreditation team will come, NMC will come, GTEC will come. You don't have this. Go and set up a disability facility. Is it the school fees you are going to depend on? So our challenge has to do with the owners of the schools taking it by the bull. Okay. This is what we want to do. Okay. And then the principals would do that. Exactly.
Thank you very much. I'm happy our president is here. Actually, I was going to start with her, but the way you ended the thing, I wanted you to just continue. So, Madam President, to add up to it in terms of the challenge, looking at the challenges that is facing the nursing, education, and practice, is there anything you want to add to what has been said already?
When it comes to the advocacy work, the association has been doing, because we are both a professional association and a trade union. So we understand clearly our mandate when it comes to advocacy towards professional growth in terms of nursing and midwifery. And we liaise with all the stakeholders, the NMC, the Ghana College of Nurses and Midwives, the Office of the Director of Nursing at the Ministry of Health, of course the Office of the Director of Nursing and midwifery at the Ghana Health Service. Unfortunately, she could not join us because of ill health. And then, of course, the other CSOs and NGOs that are related to health.
Okay.
Now, with education, we have consistently said, and I think I mentioned it yesterday and earlier today, the Health Training Institution Secretariat has done a lot of work. The last time, I think we met at the Ghana Shippers Authority Conference Hall, where it was more of a technical engagement to brief stakeholders on what the HTI under the ministry had done so far. 40 schools have been identified to be in the capacity to run the BSc programs.
Oh, okay.
Let them do it. It's about time we hold the bull by the horn and do what we need to do. We've wasted so much time with that because the conditions under which you can become a specialist, you need your BSc. The way the world is going, we need that kind of focus, expertise, so that in time, all communities will have access to specialist nurses who can serve their needs. We continue to train high numbers, and at the end of the day, they are not employed. What is the use of a nurse or a midwife who cannot practice her skill and just sits at home and 2 years, 3 years, how are we benefiting from that person? That individual needs to be on the job, whether public sector or private sector.
Okay.
So we need to be able, and we are hoping that government will understand this and do the needful. It is not, you cannot just decide that, okay, a lot of countries have identified that our nurses are actually very good. I remember during the time when the UK wanted to sign the partnership with Ghana on exportation of nurses, and we complained because we felt that UK was inadvertently already receiving the nurses because they were going on their own. And at the same time, they seemed not to be ready to sign the MOU because we put some technicalities in it to allow the country to actually benefit more from it. And they delayed. At a point, I engaged the officer in charge of, in the UK, in charge of international recruitment. And she said something very interesting. She said, we don't know the magic wand that you have in Ghana, but your mental health nurses are fantastic.
Wow.
And we wished,
I think we should clap.
yes, and that they wished Ghana could invest more in there and have a lot more of them to serve within their NHIS and other places. It's not just about mental health nursing. The specialists we train who move abroad, even the general nurses, there's, I don't know, and maybe we have to probe that magic, but somehow, somewhat, maybe it is part of our nature as Ghanaians. We are able to go way beyond what is expected of us. Which means that if the circumstances in our own country was the best,
Yeah.
in fact, nobody would carry their bags and go. This morning, one of the panelists said, what are we looking for? We are just looking for a good house to live in.
A car.
We are looking for a good car, small car to run around. And at the end of the day, give me a good enough remuneration with which I can pay my medical expenses, take care of my children's school fees and all of that. And I'm good to go.
That's all.
And if we improve the infrastructure in addition to decent work, what I've described is all about decent work where there's good remuneration, good conditions of service. If we improve the health infrastructure and ensure that beyond our tertiary hospitals, beyond the regional hospitals, at the district level and sub-district level. We improve the infrastructure of our health facilities, get accommodation around for our health professionals, especially our nurses and midwives. Then people will be more willing to move to those areas to go and work. If they are there working, it means the population has access to good health. And they are able, with good equipment and all other things needed, able to practice. So we have the fundamentals. And I agree with my sister when she says we have a lot in our strategic plans, a lot in our policy documents, a lot everywhere in terms of what has been documented. What we need to implement to make the system better is what we need to focus on so that education and practice can get better in Ghana. Thank you.
Madam President, still on you. You have mentioned a lot. I mean, you have touched on the migration and a number of things. Now, you said we have policy documents and things. So where do you see the gap? Where is the gap?
The gap is health financing, because when you take the national
maybe at
budget,
the level, you can look at it at the national level, you can look at the facility level, or even wherever they are working. You know.
I'm taking health financing from the national level.
Okay.
Because consistently, Ghana does about 8 to 9% of the national budget as allocation for health. We haven't even gotten to the 15% minimum that the Abuja Declaration, we had our own governments signing up to. The difference between 9% and 15%, which is the 6%, can make a huge difference in the health sector. It can ensure employment of our younger colleagues, it can ensure improvement in infrastructure, it can ensure improvement in equipment that are made available. So we need to look at health financing. Now the world is changing. The United States has withdrawn a lot of funding through its agencies, related agencies, and so on and so forth. It's about time we look inward and see how we can improve finances. It's not the best that we continue to be on IMF program as a country. And it's not just Ghana, a number of countries in the African region and in the sub-region. So we have natural resources that can actually fetch us money, but we don't process it. We don't process these things, and therefore earnings continue to remain low. That is one big area. But of course, we know most of our facilities, they don't get any GOG from Government Consolidated Fund. What they rely on is the IGF. And IGF, they will tell you, it's not able to even finish running services to be able to pay other things. So the bigger picture is public services. Health is a public service, just like education and others are. So every government needs to look at it holistically and provide the funding that will support it. So if you ask me what is the gap, one is funding. Two, probably I would say has to do with our political will, where sometimes, because of change of government and depending on which party is in power, priorities change, focus changes, and things are looked at in a different setting. But health, as it were, does not know political parties. When COVID came, they didn't know that this was NPP or this was NDC. There was nothing like that. Health is universal. It is the right of every citizen and on all populations to have access to health. And therefore, issues that has to do with health should not be politicized. It should be looked at through a lens that will allow every government to have the political will to make the change. Health infrastructure, like I mentioned, is still a big issue. Some of our essential medicines, even last year, was it early last year, I think, there was shortage of vaccines for babies. And you know, the periods that they are supposed to, mothers were crying out there. Where were the vaccines to be given to the children? And we cannot afford to have shortage of these things because it's essential. And at the end of the day, if you look at all the issues from the different angles when it comes to practice, it boils down to money. It boils down to money. Money is number one, but of course, the political will at any point in time. And what management of our facilities and what they do with the IGF is also of importance, because the little that is available can actually have impact, if applied properly, can have impact in terms of ensuring quality of the services provided and making the nurse or the midwife comfortable in terms of what it is they need to work with and what it is they need to do.
Thank you very much for all that you have said. You have mentioned funding, infrastructure, and a whole lot. I want to find out from you. All the... It's just a follow-up, because I'm interested in the point that you have said.
Okay.
I'll get to the other members to talk, but you know, in all that we are doing, the patient is the center or the focus. So I just want a brief comment from you. How do you see it in terms of the care we provide at the facility? Does it affect patients? Does it affect health outcome in terms of the gaps that you have mentioned briefly?
Of course, it affects patients' outcomes tremendously. And look at a scenario where a patient comes to the OPD, goes through consultation, or comes to the emergency, needs to be admitted, and that individual does not have the resources to, and I'm talking about money, to do the investigations that are requested, or to have money to buy the drugs that are required. At the end of the day, it means the condition he or she has will escalate, and if we don't take care, we will lose that individual. So funding of our health facilities, funding of our medical insurance is crucial. If we have, I'm sure there are a number of you who have found yourself in a situation where you have a patient who has come in, you have the knowledge to change the patient's condition, especially in emergency situations, and yet you don't have the equipment, you don't have the medications or the resources you need to save life. We've all found ourselves in such a situation before. I remember when I think that was around my third year. A young man who was involved in a motor accident was brought to the accident and emergency of Kolebu Teaching Hospital, and he was bleeding, and virtually we could not do anything. And it's like the patient is lying there and you are just looking on. And we looked on because afterwards the blood was coming from the nose, it was coming from other orifices, and this was bright red blood. So it meant it was direct bleeding from the brain. And in other jurisdictions, the next step would have been immediately the scan, you know where the bleeding is coming from, go straight into theater, what needs to be done. And the scenario I'm painting, it tells a story of our emergency services in Ghana, which is not the best. We have ambulances, but the ambulance will tell you before they move, you need to buy fuel in the car. I found myself in that situation before. And you have to pay for fuel before they move. And when they end, there's something they request of you in terms of, I don't know. But even these ambulances are not readily available. Sometimes you call, it takes them a long time, and it's not available in all communities. Emergency services, as it were, does not really run well in our country, and therefore it affects patients' outcome in every way. So whether it's outpatient, inpatient care, at the end of the day, the lack of resources and available, sometimes expertise affects patient outcomes in so many ways.
Thank you very much. So just realize that if it has to do with policy, resources, regulation or the mindset, we need to be very careful, because at the end of the day, the recipient of our services will automatically be affected. Now, I want to, yes, and it can be us as well. So I want to invite the other panelists to talk about it. I'll invite Mrs. Jima to just say something small about the challenge affecting the future of the nursing and midwifery practice. Just one sentence or two.
Thank you very much. One challenge I am also looking at here is how can we continue to maintain or bridge the bridge between theory and practice, looking at the number of students that we try to churn out these days, looking at our infrastructure, our facilities, are they adequate enough to accommodate these students when they go to the clinical side to practice? Is becoming a big challenge. And the brain drain that has bedeviled the nation. So when they go to the clinical side, the little competence hands that are available, they are overwhelmed with work. So dividing their role between supervision and attending to the needs of the patient is a challenge. So we want to look at the number of students that we are churning out. Of course, we churn them out and most of them are sitting in the house. Can we look at the quotas now so that we stick to the quota that probably the ministry will give to us, and not going to negotiate that I want to increase because maybe I want IGF to run the school? It is good, but the future of our patient or the future of nursing and midwifery practice is being jeopardized in a way. And so I see that bridging the gap between theory and practice has some issues there that we need to look at. Thank you
very much. So we are happy that the immediate past president of Cohete is here. When the quota is given to you, please work strictly with that. Last comment from Mrs. Evelyn Amwako on the same issue, and then we'll move to the next major question.
Yes, I want to piggyback on the theory practice gap. Beyond the numbers, you are also looking at the connection between educational institutions and then the clinical areas. For a program or for a practice that is skill-based, you expect that the people who are teaching the skill-based courses are abreast with the changing trends, what is going on in the clinical areas. And that would mean that we should have our academics also practicing in the clinical sites. Earlier on in the morning, somebody mentioned clinical faculties. We haven't really been able to work towards ensuring that there is no disconnection, or we are not working in silos as academics and as clinicians. And so that gap also needs to be bridged so that the students we are churning out, tutors are abreast with what is going on, the changing trends, the evolving trends, and then the students are also benefiting from it. And with your kind permission, because I may have to leave along the line, permit me to say a few things to some of the earlier things that have been mentioned. With regards to the transition processes for the nursing and midwifery training schools to transition from diploma to degree awarding, just to say that a lot of work has gone on in that area. And as Madam President mentioned, like we all know, about 40 schools have been identified as ready to or as able to begin the BSc programs. But let's also know that we also have to fulfill regulatory and legal requirements. And so for every school that is going to run a BSc program, it means that the tutors that you have in your school should have MPhil, masters or above in in the subject areas that they are going to treat. And so those are some of the bottlenecks that we need to bridge. And this, the ministry has shown commitment. There are plans. The minister mentioned earlier, I think not on this platform, but in another platform, support to be given to tutors to advance their degrees to PhD levels. And so those are some of the bottlenecks. There are also infrastructural requirements that schools need to be able to transition. And so those are some of the things that we are working on. But clearly the pace we are going shows that there is commitment to work on that. And then also to highlight on the importance of leadership. Leadership it's very important. Leadership in the management of our institutions. The need for partnerships, the need for innovations. Yes, government is expected to provide the equipment, to provide some of the things needed. But let's also know that it is practically impossible for government to provide everything. And so how do we bridge that gap? How are we innovative as leaders? How are we innovative as managers in engaging in partnerships to ensure that the things that we need, we are also able to engage other partners to support what we require? And I give an example of, I think was it last year or 2 years, when we went to the selection conference of the nursing and midwifery training schools of an institution, I think it was somewhere in the northern part of the country, that had in its own way written proposals to look for grants to support their skills lab, to support the work that they do. And so we need to be innovative in some of these things to ensure that we are also contributing our quota as leaders, as managers, in what is expected. And because it's 3:35, please permit me finally to mention something about the accelerated program that the Honorable Minister mentioned yesterday, and it generated a bit of discussion earlier on. Rest assured that there are no shortcuts in the processes towards it. As mentioned earlier, the associate program is already being rolled out under the Ghana College of Nurses and Midwives. And in the discussions that have gone on, the Ghana College of Nurses and Midwives, the Nursing and Midwifery Council, have provided guidance along the processes. We are mindful about the curricula that has to be followed, because at the end of the day, you want to be able to produce graduates that are not just meant for Ghana. And so we are mindful about the curricula. We are mindful about the contact hours in terms of classroom training, the contact hours in terms of the clinical practice, clinical site. And those are all have been taken into consideration. And so definitely the need to engage more stakeholders is important. And definitely before the program is rolled out, stakeholders in service delivery, stakeholders like the association and other key stakeholders, not just in nursing and midwifery, but stakeholders in the health sector, will be engaged before the rollout of the program. And there may be, I'm not the moderator, but I was going to let GCLM add on for me.
But I know she has to leave, she has a flight to catch. That is why she's trying to say all that she has to say. But we are happy that you are going to engage our president, because we're all taken aback when we heard that they are going to start it next year, and then our president is not involved. I think it's something that is worrying. So please do that. And I believe that, like what she said, let us take the opportunity and do our BSc and do our masters if there is an opportunity, so that we can roll up the nursing, BSc nursing. So with you can please leave. So Let's put our hands together for her.
Okay.
Wish you all the best and safe flights. So we are moving
Can I
to
make
our
comments?
next major discussion. And Mr. Otua, this question is directed to you. I want to find out from you, looking at all that we have discussed. So to build the future workforce, what 3 critical reforms should Ghana prioritize in nursing and midwifery education?
Thank you very much. I think the first is what we are doing now as Ghana College, where the shift is getting nurses who are well specialized in the areas that they want to practice. And currently, as you are aware, we are training, we have about 22 faculties that is going into the training of specialty areas. Now, what we need to also prioritize is the fact that we have to actually get a lot of funding to support training of specialist nurses in Ghana, because most of our residents who come find it quite difficult navigating the course because of funding. This year, for instance, we've admitted close to about 600 and something residents. Unfortunately, not all of them are able to come to school or to college, because some have written for deferment due to financial problems. The third thing we need to also look at is how do we build infrastructure so we can be able to help in training specialty programs. Ghana College is currently facing this problem in the sense that where we are now is the place for ETI. The college has acquired a land close to Get Fund, and we are still grappling with the issues of getting funding so we can have our own infrastructure, because support is not coming from government. So we need to fashion a program where we can be able to get funding. What we are trying to do also in reference to that is the fact that we've contacted Get Fund, and they've indicated their interest in trying to help us, hopefully coming from next year. But that alone cannot help us putting up the building that we wanted, because the college is growing. And so if we needed to do something, we need a lot of funding. Now, when it comes to the training, we also realize that because we don't have infrastructure, we need to open up centers. So because we don't have the clinical centers to be able to roll out other programs that we want to. We don't have the faculty to roll out the other program we want to roll out, because before we start a program, we need to ensure that we have the faculty, we have the facilities, we have what it takes to be able to meet the standard of a modern specialized nurse or midwife. So the problems are myriad, because as we speak, we are trying to get funding in support of some of our residents. And for the first time, college has established the fund, what I call the grant and research committee fund, where we are trying to seek for sponsorship to raise some money so that we can be able to sponsor some of our residents. And then we're also trying to expand the training. So we visited some sites. We went to the northern Volta region, for instance. So we are going to be starting one program in addition to what we already have over there. We also went to Western North. Unfortunately, we couldn't get what it takes to be able to start the program there, because we needed to have facilities that can be able to match the programs that we want to roll out. And so we are looking at these problems. In fact, it's only 3. There are a lot of them.
Okay.
But for us, we are trying to navigate these problems in a way and manner that whatever training that we provide doesn't compromise the quality that we are looking for.
Okay.
Yeah.
I just want to make a follow-up to the question. I just want to find out, in terms of the reforms, I want to find out about the reform in our nursing and midwifery training. Do you think that we need curriculum reform, or in terms of the approach that we teach or facilitate, or we need both?
I think we need both. Okay. We need a very strong reform. We also need to look at the approach to teaching. And I'll give you a typical example. When I was in nursing training, by the way, I'm also a very active GRND member. Yes. When I was in nursing training, I never liked research. Simply because the approach to teaching did not make me understand what exactly I was doing. So we were done with the theory, and then they asked us to bring a topic and go and start doing research. So we were asking ourselves whether we are going to be looking at the advantages and disadvantages of what type of research. You see? So I believe that what should have been done and what should be done now is that when you are teaching somebody a particular thing, you need to have the person go through the practical aspect. So if you are teaching me to go and do research, and you teach me about what is research, the type of research, the next thing you should let me do is to give me some practical hands-on work in the classroom. So that when you ask me to go to the ward and pick a topic as an assignment, and I come back, I can be able to tell you exactly how I'm applying what you have taught me. And so we need to look at the curriculum. Ghana College, for instance, we have 70% practical and 30% theory. And I'm sure most of you who are currently in year 1, block 1, will realize that you had just how many weeks of your theory? How many? 5. And now most of them are going to the work for the rest of the block. The idea is that whatever you have been taught for the 30%, you should be able to go and do more of that. And that's the only way we can refine the kind of learning, teaching and learning that we want to do. If we don't do that, we'll continue to come back and be discussing these issues, and we'll be having this idea of learning, writing, pass and forget, which will not help the system.
Thank you very much. I want to move to Mrs. Margaret Mary. Now, in terms of the curriculum that we are using, and then the approach to teaching, what is your major take on that? Do we need to have a particular way? Mr. Otuya had just mentioned having more practicals. Is there anything that you would like to add to it?
Thank you for the question. To add on to what my brother has just said, the curricula are reviewed at the NMC level, even though they have the input from the training institutions. I believe they bring other key stakeholders and they look at international best practices as what needs to be in the curricula. That is how come President mentioned that our products are really top-notch when they go out there. So the curricula, I believe, are up to standards. They have just reviewed them recently. They are yet to give them to the training schools. So I believe it's up to standards. What is left has to do with the teaching, as said by my brother again. By the college level now, we have most of our faculty doing their MPhil, some even PhD. So if the right tutors are assigned to teach the research or topics that are the subjects, various subjects, I believe the students will come out and the way that we want them to be. For the faculty, we really have them, and the methodology, pedagogy, we have it. Just that we have to assign the right tutors to teach the right subjects, and then we supervise them. These days, unfortunately, some of them, because of motivation that they are not getting, they have to engage in other work somewhere. They're supposed to get the usual book research allowance, which they are not getting. So apart from taking time to teach the usual students at the assigned college, some have to take up other courses, so they may not really have time to take the students through what they are supposed to do. Okay. So if all the necessary things are put in place, our faculty will be motivated to take the students through what they are supposed to do. The curricula too, I believe they're up to standard.
Thank you very much. Mrs. Jima, they mentioned that NMC is responsible for the review.
Yes.
And one of the challenges that I personally have is the way our patient care study is done. We have done it over the years. You see students taking grandfather, reproducing it, and they're looking at the things we do. What is the council doing in terms of the curriculum that we are using?
Thank you very much. To start with, because she has mentioned that we review the curriculum, yes. We have just finished reviewing our curriculum, and very soon, probably by next year, next month, we should be launching it. And this time, it used to be objective-based, but this time we have moved to competency-based. and the competency base is going to address not just the skill, not just the knowledge, but it will also address the attitude of our nurses, because it's becoming a big challenge, the public complaining about the attitude of we nurses and midwives. So by the time you walk through the training for 3 or 4 years, you should have some attitudinal change, and then you can come out to practice as a well-baked nurse. Coming to care study, grandfathering, and all that, together we regulate. We should be able to collaborate enough. We, NMC registrar, is not in the school. The institutions have been given that authority to ensure that students take cases, follow up the cases, nurse the patients to their discharge, and even follow up to their homes for completion or for continuity of care. And out of that, they generate what we call the care study. And so if at the institutional level you are failing to supervise to ensure that students follow the due process to do what is right, Madam Chair, we are failing ourselves.
Okay.
And it should not just be blamed at the doorsteps of the regulator. The regulator has given that opportunity or that authority to the institutions to oversee that these things are done and done properly. So if we fail at that end, we should just tell ourselves that we are failing ourselves and not just the regulator. So it is our collective responsibility to ensure that the students that are in our care, be it at the clinical side, be it in the classroom, we guide them to do what is right, upholding the ethical right to do what is right, upholding the ethical standards to do what is right. The onus is on all of us, not one individual. Together, we can regulate. Thank you.
Thank you very much. So, my dear tutors who are here, when you are giving a student, please follow up and make sure that they do the right thing. Mrs. Margaret, I think I want to ask you a question. Now realize that when you take other professions, they have the mandate to be on the ward, teach their students, take them through clinical practice, but we have a lot of nursing tutors even at the NTCs and the university. We teach the students, but however, we don't have any clinical. How do we break that gap between the teaching that we do in the classroom and then the practice? Because we are looking at the future of our nursing profession in the next 5 years. What do you have to say about that?
Every faculty member needs some practical experience to give as example to students as she or she teaches. Again, if you teach only the theory and nursing is more of practice, you don't have the skills, you will not be able to really give that demonstration of the procedure to the student nurse. And when the student is doing a written demonstration and the faculty hasn't got the technical know-how because you have not been to the ward after completion, you don't know what is happening there, updates. So it's a blind mind leading a blind mind. So the outlook of the nursing that we are trying to have a standard one, it will not come to pass if you continue to only remain at the school level to teach and not to go to a clinical training site. I know we have the faculty logbooks, which every semester, the principals, program heads, academic coordinators are supposed to see to it that when school is on recess, the faculty, they go to the clinical site. If it's midwifery, antenatal, depending on your specialty area, you go and sharpen your skills. But the fact is that these days, we don't do it. What is the reason? It boils down back to the numbers that we have. If you have in a class about 400 students, you are teaching, you have to do continuous assessment, you have to mark. The case studies you are talking of is the same tutor. Maybe I've shared the students among the tutors. I have about 20 or 40 students supervise them on research and case study. The same tutor is expected to do conference marking, to submit results within a specified time. So they end up having a lot to do. They're not able to do it. So that may be the reason why they don't get back to a clinical site to sharpen their skills. So I believe that if the ministry really takes its mandate to put in the resources that we need for our schools to work well, and we go back to the days where we used to admit 20 students per program, per class, even maximum. It is not the joy of principals who have 1,000 student population. No. If the resources are provided by the ministry, I continue to mention the ministry because the ministry owns the institutions. Just like they built E-blocks, they can equally build H-blocks, signifying health, across all our 80+ institutions, and provide needed skills labs. So in that state, the principal can go by the quota that we are asked to go by. If I'm asked to take 30, 50, a tutor standing in front of them will be able to monitor each student very well, do the continuous assessment, do all the marking, and have enough time to get to a clinical site to take up some experiences there, which will inform his or her teaching. So the main challenge boils back to the number of students that we have. And why is this happening? Now that I have the mic, let me make mention here. We don't have any other income apart from the school fees, which is itemized. And instead of the ministry resourcing us, they're opening more schools. Do we really need more schools? No. Each politician wants to have a nursing school in his or her constituency. As we speak now, we have over 5 of them that are coming up. When are we putting a stop to the opening of new schools and refurbish the existing ones? Let me use the words. Let us retool the existing schools. We have the capacity to train the BSc, the specialization. The same schools that you say we don't have the faculty. It's this faculty that in collaboration, we are training with the Ghana College, we are training with the universities to do BSc program. And our faculty are being pushed because we are not allowed to start the BSc and specialized programs. I'm also making mention that the 40+ schools that they earmarked to start the BSc next year is just on the drawing board. It's being reviewed downwards, and we don't know when we are starting. There have been several meetings that this has been discussed. At another meeting, no, we can't afford all the 40 schools to go. It's based on merit. So NMC will come, GTEC will come. So the 40 school, Madam President, is something that it was just in passing. It's been reviewed downward. We don't know the number.
Okay.
And the Mahama Care Program too, they are having the meetings. The ATIs are the implementers. As I sit here, I was the committee president. I've never been invited to any of those meetings. So we don't know what is happening. Our faculty, nurse educators group, I believe they are also part of that discussion. So you cook something, you bring to us to implement. At least here are inputs. Madam President, Ghana College is also part of that discussion. So what is happening? At one stage, ahead of the 1-year scratch program, at another meeting with GTEC and the NMC, it was also mentioned it's 2-year program. So the dust hasn't really settled. And since the implementers are not part of it, the professional group is not part of it, we don't know what is happening. I'll end my case now.
Okay, thank you very much. Thank you, thank you, thank you. So we just want to take your final comments. So maybe if there is something you need to say that hasn't been said, you say it so that we can take questions. So each panelist will give us your final comments. So we'll start from our dear Madam President.
Thank you very much. I won't say much. I will just want to retrace the points that all these bodies need to continuously work together. And we need to work together with our partners, the Ministry of Health, the Ghana Health Service, and other implementing agencies. And as nurse leaders, we need to find a way of engaging and putting our heads together to push the nursing and midwifery professions forward. A meeting here is good, but we can't wait for just conferences. We must find a way of engaging seriously so that the gaps we have identified, especially when it comes to the lack of invitation for crucial meetings that are related to the profession, we find ways to mitigate it and find ourselves seated at the table to influence whatever policy that's thereof. When it comes to the Ghana Registered Nurses and Midwives Association as a professional association representing all nurses and midwives in the country, I think we are doing our best. We are doing our best, and looking at where we are at this time, I can say for sure that going into the future, things can only get better. And we have the men and women seated here and those online, and so we'll continue to grow, but we cannot grow in isolation. The regulator needs to grow. The directorate under the Ministry of Health needs to grow. The Office of the Director of Nursing within the Ghana Health Service needs to grow. And we have to impact the leaders in the various regions, the various facilities, so that as a unit, we can push forward what is right and just for the nursing and midwifery professions. Thank you.
Thank you very much. To your final comment on the outlook on nursing and midwifery practice and education.
Thank you very much. Just to add that there are some few issues going to the future which I want to address, especially relating to our midwifery programs. Our colleagues who are having the advanced midwifery are having issues with some of the facilities, especially those who are in the CHAG institutions are okay, but those in Ghana Health Service have issues. The issue is affecting practice, it's affecting our future training in that sector. But what we are trying to assure you of is that we have had extensive discussions with the Ghana Health Service, and then what they are seeking is that they wanted to be sure that whatever training we give you is of standard, and that they wanted us to provide them with the scope of practice, which we did. So we contacted the NMC and the GCNM, we came together, we drafted, we sent to them. So I just want to let you understand that don't be discouraged. The future is bright for all of us. And then also, we are in the process of developing the scope of practice for all the courses that we are running at the college. And so the college is standing for you, which is why it's called the Ghana College of Nurses and Midwives. We know there are a lot of issues at your clinical sites, but we are working hard to ensure that those issues are done. Also, to add that going forward, we will be looking at trying to introduce some other programs. But again, like I said, before those programs are introduced, we need to make sure we have faculty. But of course, we are thinking of having endocrinology, cardiology, and of course, because we look at how we have these current issues of NCDs, we think that we cannot match, the government or country cannot match these diseases if we don't have training, and not training for the degree, but those who are specialized in these areas. So some of you can be thinking along that path. We're also thinking of introducing in future forensic mental health nursing, because we also believe that a lot of things are happening to people. What in the weekend we saw a video of somebody who was beating a naked woman, and I'm sure this person would have been arrested, taken to court, jailed, without looking at the person's background. We think that if we have nurses who can assist in this area, it will also help. All right, you remember somewhere, the first term of President Mahama, somebody went to court, somebody went to his church and said that he should have been the president and he was going to shoot him. I don't know if you remember that story. What happened? He was taken straight to jail for 10 years. The person was not assessed to determine his criminality issues. And so we think that the college is standing in to start some programs that can empower nurses so that when people are coming to the clinics, we can be able to assess their forensic analysis and other things that we need to present to court or the police for them to process in the things that they want to do. And then lastly, before we leave, I also want to encourage those of us who are having issues with the admission processes in terms of study leave and all that, to make sure that before you apply, you have your HR approve your study leave, because we realize that most of you were not giving admissions simply because you don't have study leaves. And a lot of you are coming, and it's creating a bit of a discomfort for yourselves and us. So we pray that going forward, you should be able to have all those formalities done so that we have everything going forward smoothly for us. Thank you very much.
Thank you very much. Mrs. Jima?
Thank you, Madam Chair. Yes, the nursing and midwifery practice in Ghana has a bright future, and it will take us to be visionary enough, be committed to ensuring that the changes we want, we put them into action. It's about time we walk away from the talking and put our talks into action so that we can see the vibrant nursing and midwifery that we want in our country, Ghana. We should also be able to collaborate well enough, just as Madam President has said. You are because I am because you are. And so we should not look at each other as though I am an association, so I should be in my corner, the regulator should be in his or her corner. No, we should be able to come together as one force and push our nursing and midwifery agenda. We should be able to embrace regulatory reforms. There are some reforms that we have put in place quite recently, fitness to practice. We realize that nurses as we are, who care for us, who care for the caregiver, you might be sick and you cannot be able to practice. You are not psychologically sound, you are not physically sound, and you are demonstrating some incompetencies here and there based on your health issues, but nobody is seeing it and nobody understands you, and it's having a toll on your practice. We have launched fitness to practice policy documents which will guide some of these issues. So you as a practitioner, you realize that no, this is not me. I have changed. Psychologically, I'm not sound. You could report yourself to the regulator. I feel I have to take a break from practice. And then we take you through the necessary, we take you through the necessary help that you may need so that you can go back to your feet. A colleague could also report that, no, I have realized that this colleague of mine is no longer the person that I'm seeing. We need to investigate because at a point in time you realize that the patient has no insight. So a colleague will report, and then we do the necessary investigations, and the needed help is given to that nurse or midwife. And then the head or the institutional head can also report. The public will also report, and then we investigate. These are not punitive issues. They are just to help our professionals so that they can stand on their feet and give up their best as practitioners. And it will also help to restore the confidence that the public has imposed in us all these years. And so these are some of the things. We also have what we call revalidation. It used to be that we just take the box, pay the necessary fees that you need to pay so that your PIN or your license is renewed at the end of the year. Maybe you present some CPD point, but this time we are moving away from that. We need to give quality care to the public. And so this time you are going to document your CPDs and how it has influenced your practice. And then you have the opportunity to be assessed by your colleagues, your patients and relatives themselves, and then your supervisor. And at the end, a report is written, maybe I think 3 years after, and then before your PIN will be renewed. That doesn't mean that the yearly PIN renewal is no more there. It is there. You'll be renewing every year, but then you have to go through this process for the PIN to be renewed at the end of the 3 years. And we also have what we call the career pathway. The career progression documents, I know the employer have developed it, But we realize that there's been a lot of confusion in the system. One person will do one diploma, at another point is jumping onto another diploma. Doesn't know what to do. And so there is this policy document, career path, which will guide you as to which level you should go at one point in time. All this document that I'm talking about, they are on our website. You want to visit there, get hold of them, be informed, and it will help your practice. Let us together collaborate and regulate and raise the flag of nursing and midwifery high, high, and high. Thank you very much.
Thank you very much. Then the validation is not going to be an easy job. Okay. Mrs. Mary Margaret, kindly.
Margaret
your take.
Mary.
Margaret Mary, sorry about that.
Yes. Colleague nurses and midwives, the outlook of nurse and midwifery is bright. It's our profession and we need to make it. How do we make it? All the policies, since we sat here, we've been talking about this document is available, this policy is there, now we have fitness to practice, career pathways. Will we really use them? Will we allow politics, put them aside and use them as they are? We need to have nurse managers stakeholder consultation. We need, just as we are sitting here, NMC, Ghana College, professional associations, the universities, COHETI, the Director of Nursing and Midwifery at the Ghana Health Service and at the Ministry of Health, our Chief Nurse and Midwifery officers. We need to have a roundtable discussion. We need to determine our profession, what we want. The way it is now is being pushed about. We have the beautiful documents that are there, but we are not following them. Today we introduce one program, the next time, no. You remember the public health nursing that was there at a point? They changed the name to community health nursing, public health nursing. We have to go back. It's like the dance we watched here yesterday. You move forward and then you go backwards. It's high time we did something. So please, when we move from here, let's have stakeholder engagement. These key people I've mentioned. Let's sit around, come out with a document and inform the Ministry of Health. This is our profession and this is how we want it to go. We need an act, I repeat it again. Just like the colleges of education when they were transitioning to degree awarding, there was an act. Why don't we have an act? We are under a unit at the Ministry of Health. Who listens to our issues? Who is the principal? That is being reset from one place to the other. There's fear. So it's not that is rosy up there. Let's put our hands together and inform the ministry how we want nursing and midwifery to be determined. So the future outlook of nursing and midwifery is bright if only we act, as I heard from other panelists speaking. We have to do it to make ourselves proud. Thank you.
Thank you very much. Thank you. I think we should put our hands together. We need to redefine that. So now we want to take questions, just 5, and they are going to use gender balance. You raise up your hand first. So I want all the 5 people to be here. I'll invite you, please. So 1, hello lady, are you coming? So 2, there is a lady. So 2 ladies, 1, 2. Okay. Yes. 1. Go ahead with your question. I'll be very grateful if you can direct your question, hello, to the panelists you want the person to answer. And please, just the question that you want to ask.
So,
oh, please, the line is increasing. Madam Chair, what do we do? Okay. So nobody should join. 1 minute. 1 minute. Please go ahead.
Okay. I'll respect the 1 minute. Now, the first one is on the NMC, the business of bring us the evidence. As regional chairman, I've submitted several of such evidences to the NMC head office. a lot of those evidences had been confirmed to be true. In fact, almost a year ago, they told me they had reported one of their cases to the cybersecurity unit. Till date, when I called to follow up, I actually follow up on the cases, and they tell me it's still with the cybersecurity unit. These things discourage reportage because it takes a lot of courage for members to actually give you this evidence to produce. And so when we produce evidence to the NMC must act. In fact, even the nurses at the council, at the regional offices, are worse off. They are worse off. So it's high time we take decisions on this. To correct it. See, it's true that we are constrained, with resources.
To them, please.
I've been at Koforidua NMTC, and I've seen what these stakeholder fees had been able to do. I've seen the impact it's made in WHO NTC, but 90% of our NTCs are taking these fees. What are they doing with it? It is not just about, we don't have the resources, so they should stop creating new schools. But we are also admitting more that the students are even more than the patients in the ward. If the mainstay of our finances is the fees, let's deal with what we can contain and manage it as such. But taking more students and overburdening the system, we would always have the problem we have. When it comes to the college.
So you are making a recommendation, right?
Yes. When it comes to the college, respectfully, I think the college is our pride when it comes to specialization. But the college is doing, the way they are handling the associate programs will come back to the issue of certificate and degree programs. Because, for instance, it's okay when you run an associate program in pediatrics. But when you begin to run associate programs in subspecialties, then you are killing the program. For instance, a program like pediatric oncology. Pediatric oncology should be a fellowship program because it's a subspecialty. And you started running associate programs in these areas only because the employer wants it that way. If we cannot gatekeep the system, people would always dilute the system for us. And lastly,
the 1 minute is up.
And lastly, when it comes to the clinical site, I made this issue at the AGM the last time. When it comes to clinical sites, the college is behaving like the hospitals are doing us favors by becoming training sites. We have the opportunity. The deputy registrar for HEFRA is a nurse. We have the opportunity to ensure, when it comes to house officers training, residence training, it is a requirement that once you are a teaching hospital, you should have these things in place. You should be training residents, you should be training house officers, and you should be able to provide accommodation for them and all these things. So the facilities are obliged to do this to renew their HEFRA accreditation. We should be able to get the National Health Insurance Authority and HEFRA to make it an accreditation requirement so that our residents don't go to the clinical sites and it becomes as if they are doing them favors. Thank you very much.
Can you mention your name? Hello. Can you mention your name and where you are coming from?
My name is Courage Arnold Yaofole Kwame Kuma, Volta Regional Chairman.
Thank you very much.
My name is Martin Anuvunga. I'm coming from Upper East Region.
We can hear you, please.
My name is Martin Anuvunga. I'm coming from Upper East Region. I have something, is a contribution or recommendation, and is directed to all the stakeholders up there, not just a single person. And our nurses are claimed to be top-notch, whether in Ghana or internationally. But in the wards, is this reflecting? To me, I will say no, because the public outcry about our nurses is very loud. And apart from poor condition of service, I have seen two things that affect the attitude of nurses in the ward. Number one is is it the right people that are recruited into the nursing training college? I will say maybe no, because most of the times it's protocol people who are recruited. I say this because years back, a colleague tutor told me, those who came for the interview, the one who had the highest mark was not picked. So it means that all those who were picked to go into training were picked on protocol basis. If not, the one who had the highest mark would have
If
been
we can
what?
keep our questions,
Among them.
so you want them to admit based on merit?
The next thing is,
Just be
we
brief,
are
please.
essential service. And as other essential service, our training should be taken serious. Why am I saying so? Some schools, when they are going in for clinical training, they made them to buy logistics, face mask, gloves, and what have you, to go and then do their clinical trainings. Why can't these things be at the hospital or wherever they are going to do the training, so that they will be able to go and use it to do their training? But the students are made to buy all these things, which is a burden on them. And when they come out, they are looking at what? Recouping whatever they used during the training back. And you see them selling drugs and all other things at the facilities, instead of concentrating
So, well
on the core
noted.
job. So I want to recommend that as essential service, our leaders can also ensure that during training, our students don't pay for things they are not supposed to pay. Thank you.
Thank you very much. Please, I'll be very grateful if you can make it brief and then straight to the point.
All right. Thank you very much, Madam President. My first concern is...
Please, what your name and where you are coming from.
I'm Isaac Boatin from Bunahaf. My first concern is about the number that we recruit into our NTCs. Initially, I know that we used to have quotas. Way back at Brokum NTC, the maximum they will admit was 150 as at that time. But now, if not that school specific, there are some schools who even have day students in the nursing training institutions, day students. So how can these people be well trained? So my first question is to the NMC. Is it that they don't have that mandate to regulate the quotas anymore? Or they can, the schools, the principals can do whatever thing that they can do in their schools? And also, non-nurses who used to be part-time tutors, now some principals select some of these people to even be their vice principals. These non-nurses will be supervising students on clinical. So what are they impacting? And also, I want to know the role of GRNMA in the regulation of the establishment of new nursing schools. Because if you look into the scope of the Ministry of Health, nurses and midwives carries the highest population. We know other professionals who are very negligible, but still they are not opening new schools to train such professionals. Why always nursing? Because I heard that they said there are even 5 already in the pipeline, which is yet to be opened or something. Why is it that the GMA and the Medical Council are not
President, we
permitted?
shouldn't mention any other association.
Oh,
Let's
all right.
use-
Oh, all right. I get that. Thank you very much. And also with the certificate delay printing, Madam clarified that it's those who have not completed their rotation. I know some nurses who are done with their rotation, have done the registration and submitted their logbook over 2 years. They've not gotten their pins and their certificates. And there are some people also in the system who are producing fake pins to members, to nurses. even with the former registrar's name at the back of those pins in this 2025. So, Madam was also demanding that we should provide evidences. I will recommend that they should provide a forum where evidences and reports can be reported directly to the NMC. If only we can be guaranteed of our security and confidentiality, then I think people will be willing to give out information.
Thank you. Thank you very much. I think Madam President will address that. You are taking note. Please, if a point has already been made,
all right,
please don't repeat it. If it's a new question contribution, you can go ahead with that.
Right. Thank you. Good afternoon. Please, I'm Hajara Yakubu, a principal health tutor, Tamale NTC. I'm also the Deputy Dean of Students. This morning, I heard a lot about AI, how beneficial AI is to nursing and midwifery. Then I was so worried about my students. We all understand that the way we were taught is not how we are teaching our children today because of computerized system. They are the Gen Zs, we call them. We say that AI has come to stay, but we are not teaching them how to use it wisely. Coming to look at case study this semester, in fact, it was very bad. We realized that it was just pure AI. Meanwhile, we are doing our best out there as tutors, training them how to, I taught family-centered maternity care for 5 years now. And when you bring your work and there's any problem inside, or even if you do a copy work, I'll be able to realize it. We teach them a lot. We are doing our best. But unfortunately, what we were taught is not what we are teaching them. Because our time we used to write case study. We will write and write and write, and then by the time you even finish writing, you have learned a lot from your head. But this time, even if his grandfather is copy and paste, they are copying and pasting. They are not even reading what they have. Okay. This semester, in fact, what they did was that they just took the guideline. We took them out there for six weeks domiciliary. Yes, 6 weeks domiciliary. We did follow up. We went and saw the clients they delivered. We did our best. All the monitoring that we were supposed to do, we did it. But these students are supposed to produce the case study in 3 months' time. And wonderfully, AI has helped them. They have all finished their work. Okay. Case study is complete.
The point is well made.
So please, let's not look at how important AI is to midwifery practice, but how effective our students will also be using it, because we are borrowing it from them. Yeah. Computer AI, we are borrowing it from our students. They are born into it and they know it better than us.
Thank you.
So I'm pleading that we look at how we can help them use it effectively.
But I think that when Dr. Kukeba was talking, as a tutor, there are several ways you can check your student work if it is AI. So probably Koheti is here. The libraries can have other things they can use to check similarity index. And then when we realize that it is purely AI, I think the students shouldn't go through. At the university, undergrad is 20%, and there's a percentage for AI. So I agree with Mrs. Jima. Let's all work together, the tutors, the students, to be able to help. Thank you. Please, brief.
Okay, good afternoon.
To the point.
Yeah, I'm called Dora Jones. I'm from the Central Region. At first, when we started nursing, it was a calling, but now it is a career, unfortunately. Yeah, and I have a lot of concerns, but to be brief, I think
Can we listen to her, please? Thank you very much.
Yeah, when I hear us say that the future of nursing is bright, I tell myself, are we giving ourselves psychotherapy, or that is the case? Because if we continue this way, we talked about the numbers. The numbers is not just in terms of recruitment. I know where I was trained in nursing, the requirement, one of the requirements was that if you do not have a hospital, you don't open a nursing institution. But now nursing has become business. And I think that if nurses should consider industrial strike,
Please, can we listen to her? Thank you very much.
we cannot always succumb to the threats from out there. Somebody talked about protocol. I am a Ghanaian, but I wasn't trained in Ghana, and I've had the experiences outside and in Ghana. And I came to Ghana before I heard the word protocol. And I wish that that protocol should stop. And I wish that even if politicians bring protocol, we will resist it. And then my next issue is, hello?
Hello, can we all be together?
One of the reasons which I think if we are not careful, nursing education will have a shipwreck is that because the numbers is so high, our tutors cannot have that individualized attention to each student. So most of the time you see that they go back and give past questions, PASCO. In fact, where I was trained, if a tutor is seen repeating questions, they can be sacked. So our students seem to be masters of PASCO. They learn to pass and they don't learn to know. So if it was left with me alone, I want to recommend that as far as health is concerned, let's ban PASCO because it has been abused. I should think it wasn't a bad reason why PASCO was introduced.
Hello. Please, let's do it quick so that we can.
I am actually calling a spade a spade. We are teaching students to pass exams, but not teaching them to understand. That is why you bring students for posting in our regions, and this person say, for example, with no offense, I'm a public health nurse. What is health? They can't define health. What is a community? Because they only learn to pass. But some of us, we learn the definition of health over 30 years and it's still with us. Unfortunately, our time, we didn't even have smartphones. And before you access health knowledge, you have to go to the libraries. So please, let's ban PASCO.
Thank you very much. I'll be very grateful if we can keep it brief. If you have a recommendation, just go straight to the recommendation.
Okay,
If it is a question, just ask the question. Thank you.
Thank you. My name is Johnson from Northern Region. I have one recommendation and one question. So the first one is the recommendation for the grandfathering of the case studies. So I suggest that maybe the schools or NMC itself should have a way in which students can submit their case studies in a soft copy format, and they should be able to check their Turnitin AI report as well. And I'm sure that will bring down the grandfathering and the grandmothering. Then two, I want to ask the NMC rep currently here about the examinations. She spoke about they trying to go back to look at what they've been doing earlier. But we all know in the last few years, they've been going the multiple choice questions. So if the NMC intends to maybe do Sankofa or go back, are they saying they are going back to the theory where we used to do write the MCQs before now going for the theory? And what informs that policy shift? Thank you very much.
Thank you very much. Next person, please.
Hello. I'm Bintu Idris from Upper West as an observant. Please, mine is a concern and a clarification to all the panels, especially the director from GNMC. Please, elsewhere in the world, we have diabetes specialist nurses. I was fortunate to go to UK to pursue a course on diabetes care, that's NMC diabetes care. After completion, I came back to Ghana. I tried to do conversion to diabetes specialist nurse. I went to Ghana Health Service, Ministry of Health, but I couldn't convert because diabetes is not done in Ghana. And a call was made to GCNMC, that was in 2021. And I was told they were about to start it, that was very soon. And since 4 years now, we've not heard anything about it. So I want to know, can we have diabetes specialist nurses in Ghana? If yes, what is the way forward?
Thank you very much.
Okay, so Thank you very much for the opportunity. I am Julius Elom Toko.
Can we be here? Thank you.
I'm Julius Elom Toko, District Chair, Aguna East Central Region. Please, my question has to do with, I want to know the scope of work and the working scheme for the health tutors since our health training institutions are being transitioned into degree awarding institutions. Because last year, you could recall that CITAG went on strike because lecturers were demanding for their grade to be at par with those at the university level. That's UTAG. And they had a long recess. So I want to ask, since we are essential service providers, should it happen to our sector? What is the plan B? I just want to ask if ministry or stakeholders over here have thought of trying to let us appreciate, because some of us are coming to academia. I'm a graduate student, so I want to appreciate that if such policies are being implemented or in place, so that at least you know. The second question has to do with NMC. I have a retiree in my district, in my facility, who is retiring tomorrow. I tried renewing her PIN from NMC, and I was given a receipt. The receipt was denied by my HR that he needed a card. When we contacted a staff from NMC, we were told that NMC have lost records of some professionals. As we speak, over 3 months, 4 months now, we've not been able to. And even when my colleagues genuinely want to go and renew their PIN, this is the same thing that they've been told. So they have to submit their certificate, their birth set, and all other documents. The last question has to do with GCNM. Our police want to ask when urology nursing will be enrolled. Urology nursing.
Urology.
Urology, yes please. Yes please.
Urology.
Thank you.
Urology. Well noted.
All right. Thank you for this opportunity. I think the first issue I want to talk about...
Hello, can we be together, please? Let's try to be together.
The rep from NMC made mention of Ubuntu. You are because I am. Yet, our people continue to complain of the bad treatment meted to them when they go to NMC offices. So if we know that you are because we are, why do we met out this kind of treatment to nurses and midwives? That's one. Number two, there is an alleged missing data in the NMC system, particularly referring to 2016 and 2017 badges. A number of our colleagues have reported that in trying to renew their PINs, they were told that they can't trace their data. What is happening in that? If it is true, what is the problem? Uniform. We have an issue with uniform. The tailors are wearing nurses' uniforms. The hairdressers are wearing nurses' uniform. The nurses are wearing their uniform. When you put these three together on a platform, you are unable to identify who is a true nurse. Who is responsible for registering the uniform of nurses that nobody can replicate it anywhere? Then finally, trainee allowance. I was happy when Madam President mentioned that health financing is a major issue. We know there are 6 building blocks that are anchored mainly on the financing and leadership. Now we give trainee allowance, yet we complain that when they finish, they sit in the house. Can't we come out with a model, a strategy, that instead of this allowance, we would rather use it to put in system or mechanisms that can absorb them after their school? This is the 4 issues. Thank you.
Thank you.
Thank you very much. My name is Daniel Denchi, President for the Ghana Ophthalmic Nursing Society.
Hello.
And also coordinator for ophthalmic nursing on National Cataract Artery Program by the Ghana Health Service. I have 2 issues, one for the council and one for the college. I know that before you are trained, you are indexed. And the purpose of indexing is to actually make sure that we know the number of people in training when they're supposed to be out, and the employer or the ministry who is having most of these trainings should be expectant of the people coming out. We do all these things, but why is it that still people will complete school and come and stay home for about 4 or 5 years before they are employed, whilst we have indexed them and we know the number coming? If we know that the number that we index is so much that we cannot take, why do we still keep on training more? Another one for the council is about, we are talking about training and numbers. We have unaccredited institutions and some kind of institutions training people. I recently found one, MVTI/Certified Nurse Assistant Program. And my check suggests that they have not been accredited. Yet people are teaching there. Our colleagues, some of our colleagues may be teaching there. I want to find out, what does the council do when people like nurses are teaching in these unaccredited facilities? Is there any punishment for our members who go and teach people in these areas by the council? We have to, I want to know, we have to have something like that. And then 2, for the college, I'm an ophthalmic nurse. I know of about 4 ophthalmic nurses who have done cataract surgical training in Gambia, duly certified, and they are in northern part of Ghana doing cataract surgeries. But because doctors don't want them to be seen as doing surgery, when they finish the surgery, they have to write the name of ophthalmologist there. Meanwhile, they did the surgery. I can give the additional information when it is due after here. And I think our college, we are having ophthalmic nursing training in the college. I don't want to see myself going to the ophthalmic nursing membership course and come out and still be dropping eye drops whilst we have to be doing advanced procedures. What is the plan of the college? Can these individuals be taken or be put into the college and council in such a way that if they even need additional preparation, so that there will be source of training for some of our people, so that whatever they've started, that people are putting their name on it. Let me tell you that even some of them train some ophthalmologists in doing surgeries. But when we do the surgery, they have to write the name of somebody there that they did the surgery. Thank you very much.
The last person, and then they will address the questions.
Thank you. Please, my name is Ibrahim Stechibo, AAK Secretary. Chairman, sorry. Please, my first question goes to NMC. Please, I want to know, do you really have a mandate in our care, in our training? And do you really have an autonomy? Because I want to know, there is a policy direction the government wants to implement. The government has never consulted you, and you are hearing this on the airwaves. You are now just to make an input. And this policy has an impact on nurse and midwife. I want to know, do you really have an autonomy? Because I know if this one happened to the doctors, they will be a bibroha. But we are not hearing anything from NMC, so we want to know, is there any gap, leadership-wise or governance-wise, that the association or I think we can help to help through that thing? 2, I want to know from our GNMC, please, we have ophthalmic schools, we have ENT schools. What is the challenge of merging with these people to train them as a specialist? Because some have already gained their degrees before attending these schools. Now, in the genesis of beginning, it was you must have post-basic or diploma before you go to these schools. But a lot of them are having degrees. And they are still being trained as well, another degree. What is your challenge with meeting with these people so that they can be trained as specialists? Then they should complete and come back to your school for another top-up of 3 years. This is what I want to ask. Thank you. And with NMC, please.
Are you done, please?
Last one. With NMC. Madam, please. Some of our staff who are working NMC, some are also complaining of this mistreatment that we are saying. We are all colleagues. Mistreatment of our nurse and midwives who are working there. They say some are on secondment. What is the procedure for our those there? What's their line of promotion? And how can they be integrated into the service? I will come back. Those who want to come back willingly.
Can you make that point clear? Is it those who are working
in NMC? They are nurse and midwives. Some are on secondment.
Yeah.
And when they are due for promotion, they must be promoted. But when you go there, the line of promotion is no other working. So what is the line of promotion for them? Thank you.
So we'll start with Mr. Otua.
Thank you very much. So I'm grateful for these questions. It tells me that you are following the college keenly, and so we are interested in knowing feedback so we can see how we can improve on our training. I will start with the last person, merging ophthalmic and ENT nursing schools to train. When I was doing my presentation, I stated that we lack capacity in terms of faculty to train. Now, college cannot just train people because there are other places where you can merge those facilities. Before we start to train or send residents to some facilities, we do assessment to ensure that those facilities can contain those residents, and those facilities have the specialists who will be in charge of training the specialists. Currently, we don't have our fellows who will be doing the training for us. And so we employ the services or we use the doctors. And so it will be very difficult because we cannot compromise quality. And so your idea is good, but the implementation is not as easy as you think. However, college is taking note of all these things because we are trying to expand. And in the future, these things will happen. And it's not going to be like what is being started now as you are thinking, because there's a difference between an ENT nurse and an ENT nurse specialist. So one can be independent, the other can be working under supervision, even though the person has some specialization. So we have to be very careful if we are training an ENT nurse or ophthalmic nurse specialist. We need to ensure that the standards are met. And then ophthalmic nursing, surgery, they train in Zambia. Well, I understand. You see, there are some of the issues. In fact, those of you who are working as specialists, you see the kind of problems you are having. Some of our specialists are not allowing you to operate the way you are supposed to. And this is the issues that we're having with the practice of our profession with our colleagues. I know that college is having talks or having stakeholder consultations. And in our coming academic board meetings, we are going to be discussing some of these issues to see how we can align some of these things. I also want to say that we are trying to do curriculum reviews. And so we are looking at how we can improve in our curricula and also get some specializations or training in these areas so you can become a whole specialist. And then urology nursing. I said again that before you can mount a program, you would need the facilities, the faculty, before you can mount a program. In fact, these are all on the drawing board. But you cannot just roll out a program without having what it takes to start. And so I want to assure you that I will carry this to my academic board and management and see if we can add it to the upcoming ones that we are trying to prepare. Diabetic, I just mentioned that we are trying to start endocrinology, which falls within what you have discussed with us. It's unfortunate that you had the training, but then you could not have the chance to practice. What we are trying to do is to do a needs assessment to understand what is the situation that Ghana is facing. Of course, with the Mahama Care Trust Fund that is coming up, it meant that we need, because diabetes is one of the NCDs that we should be working with, we need to get specialists. So perhaps we need to tap into the fund to see how we can get some money to train some of the specialists. And then before that, of course, Ghana Health Service must also accept so that when we train and you go out, you can be employed accordingly. Clinical sites issues. The issue with the sites is not like we think that we are doing service or we are, I don't know how to put the word. We are not just sending the residents to the clinical site, or we are not choosing site because we just want them to go. The issues are difficult, to be honest with you. In fact, these current first years, I already mentioned the hospital, we send first year associate members to a hospital. And the specialist said that he was not going to accept them. The reason is because when they were coming with the already existing specialists or residents who have been going to that facility, he was not informed. But we have written to the hospital, we are sending people. The issues we are facing are very, very difficult, and we have to be diplomatic in solving it. Because it seems to be like there is a rift. Training specialist nurses who are going to also be working on the ward with our colleagues, and I think it's creating a lot of issues. So sometimes there are some of the facilities that we find it very difficult to send our residents. And so it's not like we are doing them a favor. It's like we need their services because we don't have the specialists, we don't have the people to train us. And so we need to be very careful how we send people, how they accept them, so that we can get the knowledge from them. We are hoping that in the near future we will have our own specialists, which is why we are encouraging that you come and do the fellowship, so that that can mandate you to now teach and then mentor your juniors. So this is very important to me, and I think that I like the point you raised. The last time you made those points, we took note of that. We are working on all of those things. We are having a lot of challenges, but we are assuring you that we are going to make sure we work on all of that. Subspecialty in pedics, oncology. Yes, so like I said, we are looking at our curricula. We are going to do review of the curricula next year. We are going to realign some of the programs. We are going to introduce some. But again, we are going to do it so that when you start, you are going to be placed in a particular area where you get a specialist to take you through the program, so that when you come out, you are not just coming out as an empty-headed, impractical specialist, but you come out to be very confident and be bold in the kind of things we do. Thank you very much.
Thank you very much. Mrs. Jima?
Thank you so much. I want to take it from the last question on secondment. Is that it? To the council. If you go on secondment from one facility to the other, for some time you still feed on your salary from the institution from which you have moved from. And so you will work in the council for some time, maybe meeting some probation issues and all that, which is normal in all sectors. It's not just NMC. And then you'll be mechanized finally, or you'll be drawn from your parents' institution into NMC's payroll. So those who came on secondments, I think 2014, thereabout, they are all now on our NMC's payroll. The new ones that have come, they are barely 2 years. And so they are still on their former payroll or with their mother institution, and they are working with us. So it isn't that we are treating them bad, but it is normal in all institutions, and we should understand that one. Care study, automation of care study, yes. Plans are on the way to ensure that our candidates submit their care studies, soft copy, online. And there are going to be plagiarism checks to check all these things, the AI issues and all that. So we are working on it, and I believe it will materialize very soon. There's another one.
They wanted to find out if you could have a forum where they can come there and they let you know those who are...
Sure. So yes, I'll communicate that to the registrar, that you need time with us. Is that not so? And sometimes, right now, last week or so, the registrar and some team, they went around, disseminating information about the revalidation issue. Those are forums that you can engage and get all the answers that you need from her. But that notwithstanding, I will communicate this to her, and we see how best we can make time for you as regulators, so that you can engage with that. Even if it's online, that we can have, zone the country and have that kind of online interactions with you, we will do. So I will communicate with her, and then we see the way forward. I think somebody also mentioned about missing data for which PIN is not renewed. I was just asking where is that one for, but then I could remember that 2014, 2016 that you have mentioned, that was the time that we started moving our data, moving away from the paper-based things that we were doing to online. And so, and looking at our staff strength, we had not many. And so, I think all the data couldn't be pulled online. There are some that are still sitting on the shelves. And that doesn't mean that your PIN should not be renewed. When you come in and you need to renew your PIN, staff should be able to fetch from the shelves, and your PIN should be renewed. So we will look at that aspect as well. I will communicate to the registrar, and then we see the way forward on that as well. Thank you very much.
I think the next...
Okay, sure. Okay, there was also a question about whether we are going back to theory. The answer is no. We have reviewed the curriculum, yes. We are going back to competency-based, yes. What it will mean is that the number of questions would probably increase. In those days, we used to write about 6 papers, the written paper. All those ones are going to be inculcated in it, but not in writing, but it's going to be MCQs. When we launch, you have better information on all that.
Thank you very much, Mrs. Jima.
Nurses uniform is, I think, Mrs. President will
address the nurses uniform.
So when it comes to uniform, it is the employer's mandate. It is not the regulator's mandate. It is the employer. So the employer determines what uniform we wear. And the one who asked the question, I was just whispering to myself that maybe he's not been to our conference before. For so many years, that it comes up every time. Can't we register our uniform? Can't we do this? But within the law, we cannot. We took it upon ourselves to go to Registrar General. And we were told, even the military and the police, their uniforms are not registered. Let your uniform speak professionalism.
Okay.
Let it speak power. From where I sit, when I see somebody dressed in white, I can tell the person is not a nurse.
Yeah, true.
I can tell. Can't you tell?
Yeah, very true.
You should be able to tell.
Very true.
That is why we should be serious professionals. We need to dress properly. Why are you saying no? We need to dress properly. You cannot stop. The truth is, if you say, the one who asked the question said, seamstresses and hairdressers are wearing nurses' uniform. Is it the green they are wearing or the white? Is it not the white?
Both.
And the green with the band?
Yes. Some do it.
Really?
Yes.
Then I'm yet to see that one. I haven't seen it.
No, some indeed add the bands to it.
They add the bands.
Yes.
And that one is serious. So we need to identify where they are having that training and deal with them. But you see, I don't know what the NMC will say about this one. But from where we sit, that's what I've shared with you. We have made an effort. That was, when was that? Comrades. That was about 3 years ago or 4 years ago. 3 years ago, we went to Registrar General and said we are ready It doesn't matter the cost involved or the processes involved. We are ready to have all the cadre of nursing uniforms registered. Then we can hold the registration as a tool so that we can fight some of these things. They took time to sit us down and explain that we cannot register the uniform and that their systems are such that it is a profession and the profession itself knows how to dress. And that the military's uniform is not registered with Registrar General, the police uniform is not registered with Registrar General, but the question is how are they able to protect it such that you don't see an ordinary person walking out there wearing the military uniform. You will be beaten. You will be beaten. Exactly. So we have to take up the matter into our own hands, but it's not about beating anybody. We will need to be more vigilant and speak out against some of these things out in the media. But I'm sure Madam will have something to add up.
I think we have said, okay.
Yes, uniforms are not in our domain, neither is it in the association's domain. Ministry of Health, I know, have come out with some designs or some uniforms. The council had the opportunity to make some inputs into all that. But the registration is the challenge, just as she has rightly said. But that notwithstanding, be a nurse, just as she said, be a nurse and don't just be a tailor. Because if a tailor dresses and a nurse should dress, there should be a difference. There should be a clear difference because during your practice or during your training, you were taught how to dress. Your uniform, especially the ladies, should be under your knees, right? Under your knees. Yet these days, what we see is above your knee. And I've had the opportunity, I've had the opportunity to sit some ladies down in my office to educate them on the profession they have chosen and the need to dress properly. And we should, as leaders, should be able, at the school level, at the clinical level, educate our colleagues. You know, come again. You see? Then yes, you see.
Yeah. Hello. So we will allow Mrs. Jima to answer, Madam President, to answer her last question.
We've seen the evidence. To be frank, moderator was telling me some of these things are happening seriously in the northern region. Kindly identify those enterprises and let us know. We will engage them very nicely to stop. Since we don't have the mandates or the documents that will help us to let them stop, we can engage them to stop creating misconceptions and confusion in our system. But the truth is, if you look critically at the style, this is not the prescribed style for nursing uniform. It is not. The pleats down there is not our style. But all the same, identify them. Chairman, do you know some of those institutions? Okay, we can engage them so that they change the uniform. It shouldn't be anything difficult. The last question which was thrown to me was about how we are addressing the proliferation of nursing schools. We have advocated strongly on this, but it looks as if the way the nursing and midwifery has been politicized, we will have to do more. Because if we want quality nursing and midwifery services, we should attach quality to the training. It is not just about opening schools and training people, and that is it. We must be interested in the faculty, in the infrastructure, and everything that there is to it. So we've heard you. We'll continue the advocacy and make it stronger. Thank you.
Thank you very much. Okay.
Thank you, Madam Moderator. I take my turn to address some of the questions that were addressed to me. There was an issue about development levy. Some schools use it profitably. Meanwhile, other schools, there's nothing happening. And example was given about Kofredua, where they've used the development levy to do a lot of things. The truth is that it depends on the student population that you have. If my student population is 350, that is the total student population of one particular school, the development levy is maybe 100 cedis times 350. It's not only into building. That's what you use for capital projects, daily operations of the school, because there's no money coming from anywhere. So that's how come those schools with the larger populations, they're rather hailed. Oh, go to school A, go to school B, they are doing a lot. You are sitting there not doing anything. And it all has to do with the quota, which was another issue we had to address. The quotas are given, we're not able to stick to them. It's not the principals. Some of us sitting here, our protocols are also part, including myself. And if an MP has set up a school where community leaders have been able to set up a school, they bring their people, they expect you to admit them once they meet the minimum qualification. So it's something that is beyond just the principal. No principal has a mandate to go beyond the quota given. It takes you and me to influence that quota. And NMC is supposed to also work with the quota given. At times it also goes beyond them. So that's why I kept saying, are we really operating what we are supposed to do? No. So we should influence what is done at the ministry level. We need this number of tutors, not tutors, of nurses and midwives. We have HR gaps that have been identified. So why do you go ahead and admit, you heard the Honorable Minister mention, every year we are sharing out about 35 to 40 students. Do we need all that? No. So that is why if you look at our HR needs, and we share them among the schools that we have, and we are really able to stick to the quota if we are giving all other resources, it will be comfortable for the faculty, the principal, to have limited numbers that you can really control, take time, know their names, follow them to the practical side. So it's all about politics and what operates in our schools. And all of us have a factor in it. Public outcry about the attitude of nurses. Yes, we are saying that is top-notch. That is those with the experience that are moving out. But those who are training now is really a worry, because they don't have the hands-on. We are all aware they are more than the staff and the clients on ward. When we are having practical exam at the ward, staff, they become fatigued. They don't want you to use them for practicals anymore. So we don't really need those numbers, but it's something that is coming up. We need to look at it in a way. The protocol admissions and day students, it still boils down to the numbers. So until we tackle these numbers, and how do we tackle the numbers? The Ministry of Health, the one who posed the question said we should not complain. We should try to do with what we have. What we have is not enough to build a skills lab. Look at the high fidelity mannequins. It's very costly. Setting up a classroom, the infrastructure, you cannot use the school fees to do that. So if the ministry takes these things up, build the H blocks and resource retool last wall, then we can limit the numbers that we have. And they will not bring back numbers after giving us quotas. So that's the real fact that we have. And it's not just day students. Some schools are running shifts. They have the green, they have the yellow class, which is war in nursing schools. It's happening. So it's really something we have to look at.
So probably the collaborative talk will continue.
Pardon me?
I'm saying that
I should wind up. Okay, thank you. Demand for payment at clinical training sites, I think that was addressed by director, but still with our colleges of HCIs, our students, some of them are turning away because they are not able to provide a glass or pay. It's something that we are trying to address as stakeholders, how these students could be accepted at clinical training sites, because they complain that they use a lot of consumables and they need to pay for that. Should it go to the student? Should it be part of the school fees? There is something we're discussing at the stakeholder level. Non-nurses acting as vice principals. It is a no-go area. So if some schools is being done, we have to inform the right authorities. It is a nursing school and it should be headed by a nurse, and the vice principal is aspiring to be a principal, should be a nurse or a midwife. But the challenge is, when now some nursing training colleges are verging into doing allied health. So if I'm running other allied health programs, and we have some other non-nurses, so you see how the issue is coming up there. Should it be a nurse who should be the vice, or it should be an allied health? But where we have these issues coming up, let's address it to the authorities for us to nip it in the bud. If not, to be worrying if we have a non-nurse heading a nursing school. Ban of PASCO, we are working on it. Scope of service for tutors. Now that we are moving on to degree awarding institutions, are we also part of the special service team? And if they're going on strike, what is our take there? I think that was a question like that sort. So far as we belong to Ghana Registered Nurses and Midwives or professional associations, that is our mother associations. So whatever that they are doing, we belong to the association and we align with what they do. That's what I have to say there. But for the scheme of service, it's on the drawing boards alongside with the conditions of service, which has to move into along as we have the degree transition. I don't know when that is coming up. It's another thing that goes on and off. Training allowance. Why wouldn't stakeholders rechannel it into employment when they complete? I think it's a policy issue that has to be addressed up there. We can only add that to our communique or as we discuss further. Because some government come, they want to continue with their training allowance, others want to take it off.
Okay, thank you very much, Mrs. Margaret Mary.
No time is running.
Come again.
It's okay, thank you.
You have more?
It's okay.
Okay, so there was a question that was directed to Mrs. Jima. Somebody asked a question about nurses training students in non-accredited institution. What is the council doing about that?
Nurses training students in non-accredited institutions. If you have some of those evidences, you want us to know. Because before a school is established, that school needs to be accredited, go through a rigorous accreditation process. And you are even invited to the council for what we call a credentialing forum, where you would tell us the things you have in place for which you should be able to run an institution. And so if an institution that has not been accredited, and you know of that institution, and you want to just step on our feet, we will be very happy to have that information. So quickly we can move to the institution and take the regulatory actions against them. Thank you.
So thank you very much. I think we have come to the end of the discussion. So the three key things we are taking away is that, number one, education reform is essential. Let's look at our curricula in terms of modernization, strong faculty development, and the meaningful clinical exposure. And the second thing we are living here with is that there should be professional empowerment matters in terms of clear career pathway, leadership roles, and supportive practice environment. And then the last one is sustainability, which requires investment in terms of retention strategies, workforce planning, and collaboration across institutions. So I just want to say a very big thank you to our panelists for availing themselves for this discussion, and then you all for your thoughtful insight. I believe that discussion is not going to end here. We are going to continue, and I believe that nursing is going to be improve a better profession for all of us. Thank you very much for your time.
Gender balance.
Thank you so much for your cooperation. At this time, we are moving straight to the next session. If you want to stretch a bit, please stand and then stretch a bit. DJ, please give us a soft music, but a danceable one. And then we move into the next session. At this time, we are inviting our resource persons who are taking us through the health sector occupational pension scheme. And they'll do the presentation, we'll have questions, and then we move on from there. So to do the presentation, the DJ is not there, so just stretch and then sit for us to continue. So, comrades, we are continuing with the session. Comrades, we are continuing with the session. And to do this presentation, we have a nice gentleman named Mr. Gayton Adangabe. He's the chief physiotherapist at the Ghana Health Service and a member trustee of the Health Sector Occupational Pension Scheme. Let's put our hands together for him. And it's good that I am on the board and Dr. David Tingranchu, my GS, is also on the board. So we'll just sit here and give him moral support as he does the presentation. Mr. Kampa, please organize delegates, observers, let them come back in and sit for this session. Thank you so much.
Yeah, good evening to you all, and thank you very much for the opportunity. Madam President, the National Executive Council, directors, delegates, I'm here on behalf of the Health Sector Operational Pension Scheme to interact with you on the Tier 2. The presentation.
Just a minute. Comrades, they are mounting the presentation. Comrades, those on the corridors, please come inside and let's continue.
No, it's okay. Just
Get your people to come and sit down. Look behind you.
Yeah, it has come now. It's come. Yeah, good evening to you all. I know you're tired, but we'll make it fast. So I'm presenting on behalf of the Health Sector Occupational Pension Scheme to you. Yeah. There is a need for all of us to start planning for our pension. If you have not started planning for your pension, you are planning for tension, you are planning for unhappiness, and you are planning for trouble in your future pension. We will look at the outline of my presentation. We'll look at the overview of the three-tier pension scheme, the structure of the scheme, how lump sum benefit payment process, how to access your account, everybody has an account, and then our contact, they will open for questions. The overview of the three-tier pension scheme. Following the pension reforms in 2010, Ghana began a three-tier pension system. Tier 1, mandatory basic pension scheme, which is SNIT, which involve all workers in Ghana. Tier 2, the mandatory occupational pension scheme, which is individual corporate trustees, and which covers employees within a particular sector. So the health sector, we have our scheme, education have their scheme, local government, and other sectors of the system. Then the tier 3, we have the voluntary personal pension scheme, which is corporate trustees, licensed. Individuals may come together. I know your association have the third tier pension. So these are the three tier systems that were established following the pension reforms. Now, as employees within the health sector of Ghana, our mandatory occupational pension scheme is the health sector occupational pension scheme called HESOPs. Now, what is HESOPs? Health sector occupational pension scheme is a tier 2 pension scheme and an employer-sponsored scheme for all employees in the public health sector of Ghana and some private health organization. It is a defined contribution, which means you get what you contribute on your investment. This is very, very important. The second tier system is what you contribute monthly. It is invested. Returns are put back in your account, and when you retire, your lump sum is paid to you. Now, this is the structure of the scheme. We have the regulator, the Pension Regulatory Authority, which is the national regulator which regulate all pensions in Ghana, both public and private. So they are the regulator for all pensions in Ghana. Then we have the Board of Trustees, and the Board of Trustees is made up of leaders of the health sector unions and government. So in the union search area, we have the representation from GRNMA. You have a representation which your president is a member, your general secretary, and 2 other are firmly represented in the board for your interest. We also have GMA represented. We also have Health Service Workers Union who are represented there. We have GOSPA. And then on the government side, we have the Attorney General, which is part of the Board of Trustees. We have the Ministry of Finance. We have the Ministry of Employment and Labor. We have Ministry of Health, and we have Ghana Health Service. They constitute the board that are managing and investing the funds on your behalf. And in the Board of Trustees, they have committees that is helping to manage your funds and invest on your behalf. We have the Finance Compliance Risk Management Committee. We have the Investment Committee. We have the Education Committee, which I'm here on behalf of the Education Committee. And your president, your national president, is also the chairman of that committee. And then the Board of Trustees has engaged service providers to support and help the board so that we can manage and invest your contribution so that you retire with a smile. So we have engaged enterprise trustees as our scheme administrators to help us manage the administrative aspect of the scheme, keep our records. Sorry. So keep our records and process benefits. We have also engaged fund managers, 2 fund managers to help us, to advise us on investment strategies based on the scheme investment policy and guidelines with the MPRA investment guidelines. So we have 2 fund managers, Bora Capital and IC, who are advising us to invest your money prudently. We've also engaged a custodian, a bank, which is Carl Bank, where your contribution, monthly contribution are lodged in. They also keep our assets and all our investment are kept there, and they also pay benefits when you retire. Now, membership of the scheme. The scheme currently covers all employees in the health sector of Ghana. So all staff in the teaching hospitals are members. Ghana Health Service, all staff are members. CHAC, the Christian Health Association of Ghana, CHAC, all staff are also members. Other faith-based health facility on government payroll. And also we have our IGF staff in our various facilities, they are also members. And staff of major unions are also members of this scheme. Now, how is this scheme funded? At the end of every month, myself and you all, each worker, contribute 5.5% of your salary towards your pension. Now, government or IGF staff, in the area of IGF staff, is the hospital or the facility. They contribute 13%. Now, when you add this, you get 18.5%. So how is this 18.5% distributed? So tier 1, which is SNIT, takes 11%. So SNIT take 11% of the contribution. They manage and they invest. When you retire, then they give you what we call monthly pension allowances. That's where it comes from. Then the second one is the tier 2. That is our scheme. It's 5%. So we also manage that 5%. When you retire, we'll pay you your lump sum. Then the third one is the National Health Insurance Scheme. 2.5% goes to National Health Insurance Scheme for your health insurance. So this is what is used for your health insurance. So basically, the Health Sector Occupational Pension Scheme is funded by your 5% contribution. Now, member enrollment, though you are a member of the scheme, especially those who get their salary from controller, but you need to enroll into the scheme for us to obtain all the relevant information about you. If you have not yet enrolled, then it means that we do not have your details and you need to do that immediately. So how do we enroll members for those who have not enrolled? Enrollment forms can be downloaded from our website. We have a website which I'll show you very soon. You can also pick the form from all enterprise trustees offices in all the regions. Also in our regional health directory, the HR department, they have the forms where you can get access to them and then you enroll so that we have your details and communicate with you. We also enroll facilities for the IGF staff. So facilities also enroll so that the IGF staff, when they pay, they also remit their pension contributions. Now when you enroll, this is the scheme membership certificate where you can download it from the website as a member of the scheme. Now when can you access your tier 2 lump sum? The first one is mandatory retirement at the age of 60. If you get to 60, then you can apply to the second tier scheme and then we can pay you your benefits. The second is voluntary retirement, 55. If you've worked so hard and you're 55 and you want to retire, enjoy your life, you can apply and we'll still pay you your lump sum. The third one is the unfortunate one. That's when beneficiary health worker is deceased. And this is very, very unfortunate, but it's very, very important that we discuss this because I'll use myself as an example. When I was employed, I kept my mother as my beneficiary and I put 100%. Years passed, I got married, I had children. I never bothered to change it. My mother passed away and I had never changed it. So imagine if the unfortunate had happened to me. My mother is gone and I'm gone. Who is going to take my benefits? And I'm sure most of you have not even check who are your beneficiaries, or you've updated your beneficiaries. So it's something very, very important that you need to look at it, to know who are your beneficiaries. We're not saying that the unfortunate thing will happen, but you never know what will happen. So we need to do that. And then we also have total incapacitation, no age limit, you can apply. And then the permanent immigration, which is for only expatriates. Now, if you go on retirement and you want to claim your benefits, you can pick up your application form from the Regional Health Directory, the HR department. They all have the forms. Enterprise offices all over the regions, you can also get your form. We also have the forms at our National Secretariat in Accra and Kumasi. So you complete the form, you submit it to our administrator, and then the vetting will start. So applications go through internal process, which may take 1 month or more. The Board of Trustees meet and approve your claim and authorize payment. So that is how the process you go through to be able to get your pension funds. Okay. Now, how can you access your account? As I earlier on said, each member has an account where your contribution comes in, investment is done, and then your returns are distributed to your account. So when you retire, that account is empty and is giving it to you. It's not like the olden days whereby SNIT, they were saying that we have formulas, and nobody knew what the formula is. This time, there's no formula. It's what you contribute every month. We invest it, we share the returns. When you retire, you close your account and you get your money and you go. So using the online portal through the scheme website, member locking. So we're using the SSD code, which is *714 *333#. When you dial this, then you follow the prompt, you'll be able to access your account. At the end of this, we will go through that process so that you'll be able to access your account and know, for example, today if you retire, how much are you taking home? You can also download the Enterprise app and go through the member portal. So this is a sample of the what do you call it, of your statement of when you go into the system. So you have your name, you have your ID, you have when you join the scheme, your date of birth, and then when you go to the what do you call a contribution summary, the number of contributions you have made, and when you come to the transaction history, it also tells you the date, the kind of investment, the units we bought, your returns, and you'll be able to see everything, track everything that is going on your pension. So why the online portal? Because you have 24/7 access to your member information, opportunity to update your beneficiaries. You have your member statement, you have your member certificate where you can print. And the most important thing is that you can access all this with your smartphone, so you don't need to worry yourself. There is a video on how we can access our account. I'll try and see whether it will be able to play so that we can all observe it. Hold on. The volume is not coming. So no problem. Well, I'll make the video available so that they can put it on your platform. But it's basically telling us how we're able to access our account. No. It's not this. The audio is not working. I don't know. Yeah. So we can move on here. I think this will be better. So this is how the system goes, how to use the SSD portal to access your account. And the first one is you have to dial the code, the *714 *333#. And then you will follow the prompt. So this is the system that you will follow to be able to access your account. We'll go through this exercise so that people will be able to do. I'm here with the enterprise team. So what are the challenges that we are facing currently? One of the major challenges is delay in payment of contribution by government. As you're all aware, every month you receive a SMS message telling you that your tier 2 pension contribution has been received and invested. I'm sure most of us, I think everybody here received that message. Who hasn't received that message before here? Because if you don't receive that message, it means we need to look at it and resolve it today. But I'm sure that all of you are receiving that message. If not, you let me know. We also lack presence in all the regions, which Madam President and the Chairman are working through to make sure that we have presence in all the regions so that people can access their Tier 2 pension information and other things. And then we also have challenges in non-enrollment of some health facilities and non-enrollment of IGF staff, which is also we are trying to address the system. So this is our website. So the website is HISOPS, HSOPS, Ghana.com. So www.HISOPS, HOSPS, Ghana.com. And then you can follow us. You can get a lot of information concerning the second tier scheme. Our office location, Accra office location, we are located in the GRNMA, Greater Accra Regional Secretariat, Zoti, just behind Kolebu. You find us there. Our contact number is 030-2690-802, and our WhatsApp number is 055-3476-478. We also have a Kumasi office location. We are located on the Ahunju Road, opposite the Zenith Bank. That's the Ahunju branch, and our contacts are also there. You can also contact us on the WhatsApp 020-037-0766. So these are our two offices, but we hope to gradually reach out to all the regions so that we can spread information of this Tier 2. So this is our contact. If you want to contact us, our email is health.pension@yahoo.com or health.pension12@gmail.com. And then our website, as I just said, www.hisops, HOSPS, Ghana.com. That is our website. You can get a lot of information. And if you want to reach us, we are P.O. Box GP 2994, Accra, Ghana, and our telephone number. And again, our office at the Greater Accra GRNMA Secretariat at Zoti behind Kolebu. Thank you very much, and we will take some questions for you. The enterprise team, please, are you around? Come. We have set up a tent at downstairs. After this presentation, if you have any challenge with your Tier 2, please feel free, come there, contact us, and we'll be able to resolve your issue. The enterprise gentleman will take us through this. It's very, very important, this exercise, so that we'll all check our accounts. I don't know. Please. Yes, this one. So he will take us through. Please, let's use our smartphone. We'll all check our accounts and know how much we have on our accounts. It's very, very important. Thank you very much.
Thank you very much, sir. Good evening, all. My name is Jackson Ibrahim. I'm from Enterprise Trustees. I'll walk you through our USSD procedure. So, anyone that has ever received a message from us, be it a birthday message, a contribution message, you use the number that you received a message on to dial the short code. So the short code is *714*333#. So dial the short code with that particular number. Then you select option 2 for my account. So the short code is *714*. Let me see if I can zoom it a bit. All right, I hope it's clearer now. Okay, so dial *714*333#.
Are you doing it? Okay.
If you are there, then you select option 2 for my account. Option 2, my account. Because we are all first-time users, we are supposed to create our PIN. So you enter 0 to create a PIN. But if you have already accessed it before, you can just enter your PIN and proceed. But most of us here are first-time users, so we enter 0 to create a PIN. After entering 0, your phone number should pop up. So you enter option 1 to use your current phone number. So you check and confirm your phone number and select option 1. If you are successful, you are required to enter your date of birth. So follow the format, the day / the month / the year. So an example is if your date of birth is 1st January 1993, you do it 01/01/1993. So you meet us outside, we'll link it for you, sir. If you are successful with your date of birth, you are now required to choose your own PIN. So your PIN is any 4-digit number you can remember easily. So you enter 4-digit PIN that you can remember easily. If you enter the PIN, it will require you to enter it again. And then you enter it for the 3rd time to confirm the PIN. If you are successful with creating the PIN, you'll be required to enter 1 to use your current phone number again. So going forward, this will be the PIN that you'll be using to access your account. So the next time you dial the short code, you will not enter 0 to create a PIN, you will just enter your PIN and then you proceed. After entering 1 to use your current phone number, you should see your membership ID. It should start with the prefix ET2M with numbers that will follow. So this is your unique tier 2 number. Then you enter 1 to select the membership ID.
Please, are you following?
Okay. If you are successful and you've selected your membership ID, you should select option 3 for account information. Okay, I think it's option 2 now. Option 2 for account information. Once you select option 2, you should be able to see your contribution. So you should see something like CTB. So CTB stands for your current contribution. Right beneath it, you should see RTNs. So RTN stands for the returns. This is the interest that you've gotten on your account so far.
Do you like the figures you are seeing?
You should see WD. WD is withdrawal, but until you go on retirement, you cannot make a withdrawal. Then you should see BAL. So BAL is your balance. So your contribution plus the individual returns would give you your balance. So should you be retiring today, this is the balance you'll be taking home as a lump sum. I hope you are happy with it. Thank you very much.
Yeah, so thank you very much. We'll take some questions and then we'll try and interact. Thank you very much. But Madam Chair he's my chairman for the Education Committee, so she's sitting here with a different hat. So permit her to join, and then your General Secretary, and then Jones, the Shanti Regional Chairman, he's also a trustee. So you can join us so that we will all take the questions. Thank you very much.
Adato, please kindly note that. And gentleman in light blue shirt, you are the last one. Oh. Are you in the queue?
Is that?
So you are the last one. Nobody comes behind you again. 1 minute each, please.
Okay.
Please go ahead.
All right, thank you for your presentation. My name is Ideas Coleman Adato from Greater Accra, and I'm a delegate. So my first question has to do with the contributions for last year. When I downloaded my statement and checked the contributions for last year, I noticed that only 7 months were credited to my account. 5 months, that's from August, September, October, November, December 2024 were not credited. For this year, well, we have received up to May. We are looking forward to the rest of it. But I want to know what had happened to last year, knowing very well that pension contributions is time-bound, and the more you invest it, the more you accumulate interest. I was also looking for some projections, or maybe some historical interest that we have gained, or some returns that we have made on the investments, so that we are able to tell that we are on the right path, or we should proceed, cautiously. But unfortunately, that didn't come up. But if you want to give it to us, we are ready, and we'll be grateful to take it. Thank you very much.
Thank you very much, Madam President. So I'm John Okanse, Regional Secretary for Volta Region. When Coleman asked his questions, I was smiling because his second question happened to be the question I wanted to ask. So maybe I'll ask in a different way. Checking my account now, I could see that the figures are good with regards to the returns. So if you can educate us briefly, what are you doing differently for this scheme? Then secondly, the challenges, you mentioned regional offices. But I'm thinking, since we have Madam President on the board with our General Secretary and Ashanti Regional District, we can link up and use our regional secretariats, those that can, or those that are willing, so that you can be paying something for rent in the various regions. Thank you very much.
Thank you for the opportunity, Madam President. My name is Deborah Betunus, a delegate BA. My challenge is that when anytime I receive the SMS, it comes with different name. So I track, and I got the app on my phone. When I went into the dashboard, I saw 2 registration numbers. So I'll be able to download the statement, the one that bears my name with the staff ID. The last contribution was November 2022. But the one that bears different person name with my SNN number and staff ID was having contribution up to date. I've watched a complaint over 4 months now. I follow up. They said they are working on it. Up to now, the correction has not been done. That's my challenge.
Thank you very much, Madam President. My name is Nafa Ibrahim from the Northern Region. My issue also has to do with the response we get from the administrators. I used to be able to log onto my account. Along the line, they sent us messages and access to re-log in. Since then, I've been trying to log in and it doesn't work. So I called Enterprise. They gave me an email. So that was June 24, 2025. I sent the necessary information to them up to date. I've not received even a reply. So how are they in the position to help people like me with this situation? Thank you.
Thank you.
Thank you, Madam President. My name is Jefferson Asayo Dankwa, a delegate from Greater Accra. Madam President, I checked the balance there. I felt like I need to retire now. It's good. And I'm sure Greater Accra, we are happy. But we are the region that hosts a lot of our members are into private institutions and quasi institutions. How will this also benefit them? Our members who are in private institutions, will we have the opportunity to also enroll? And looking at how good it is, almost about the best investment or among the best investments in Ghana currently. Will there be an opportunity for individuals to invest more, or better so, increase our investment? Thank you.
Thank you very much. My name is Mohamed Amin Bamba, Northern Region. Please, Madam Chair, my question has to do with because of the economic difficulty Ghana went through from 2022. We heard there is some haircut. I want to find out whether the haircut has really affected our investment or our investment is still intact. Thank you very much.
Thank you. My name is Abraham, AAK Chairman. Please, my first question is, we know that we can all testify that when I check my account, I'm having Abraham. I'm having some 20,000, but 20,000 today cannot even buy a tie of Korea. So imagine I go to retirement and I'm giving, say, 2 billion. It can't even still buy Korea. Korea. I can't even buy it. So my 60 years of work as a nurse can't afford Korea. Madam President, this is the state of a nurse. That's, as a nurse, our 5% can't even buy a Korea. Please, please go ahead. Can there be a policy variation so that I can have that money now to invest into an asset? So that today, if you imagine I have that money, I can buy maybe 20 bags of cement and build a house. I'm making some profit. Then leaving that house, leaving that money to 20 years, and I'll go and return, I'll be maybe 2 billion. I can't see that Korea. Madam President, please. Am I working for a deficit or I'm working for a profit? Am I working for a profit or a deficit? Yes. Have you finished? No. Secondly, what we are checking now, I want to know if you are all investing, is this a pool fund that if 20 people contribute the money and they invest, the investments, the returns on that investment will be bigger than one person investing. So as we are contributing the money, is a pool fund that they are investing all our money and share the profit for all of us, or is singularly? That's what my second question. Because I know that if imagine 50, all of us here contribute 50-50, they invest that money, we get more profit than what they are doing now. Yes. So these are my two questions. Thank you now. Maybe I will come back.
Okay, thank you very much. Please, I want to find out if we can use the funds we have for mortgage as an individual, if we can use it as mortgage. Then also, we are in an era where people travel out, migrate out of the country. So what happens to those contributions when maybe in case the person travels out? Thank you.
Thank you. Madam President,
I'm Thomas Asafoje from Ashanti region. Please, I want to find out from if there are any plans. From the figures, for me, it looks good and you have done well. I want to find out if there's any plans to allow contributors to increase their contribution in any form per their own personal arrangement in such a way that when they finally go on pension, they can enjoy more. Thank you.
That's the last one. Last one. Please.
Thank you for the opportunity, Chairperson. Please, I want to ask, I have a friend who is deceased. It's been years, but there are issues with both families. So I want to ask, anytime, if they settle their difference, can they come and assess her benefits? And the other issue is, I checked my balance and it was quite good, but I'm surprised senior colleagues who are retiring, when you speak to them, it's like they are not going home with anything and they are in despair. So I don't know whether they didn't benefit from this scheme. Thank you.
Yeah, thank you very much. From the last question, you were saying our older colleagues who retired complained that their retirement was not good. If you follow the presentation, I told you that there was a pension reforms. And we are all aware during the SNIT time, before you retire, you don't even know how much, and they use formulas and all kinds of things. So the new 3-tier pension scheme has resolved that issue. So what is happening now is that your contribution is 5%. It is invested. You get returns, and when you retire, we give it back to you. SNIT, those days, SNIT, if you go through SNIT, their annual reports, past years, they were using almost about 30% of our contribution for administration. Now, if you use that amount to do administration, you don't expect the member to retire and get any good pension. But this time, the law has changed. And it is such that your contributions are used to invest. And at the end of the day, your returns are better off. That is why now with the new reforms, you are seeing that our figures are going up. And with time, health workers would retire with a bigger smile, because as the years go by, your contributions are managed properly. And the most important thing is that it's your own members, your leadership are part of this scheme. I'm not sure President will sit down and allow anything to happen to your funds. That is why now we are getting good returns when we retire on our lump sum. Then the other question, the other question was to increase, somebody asked whether you can increase your contribution so that you can retire with a better or a bigger amount when you retire. Yeah, the 3-tier pension scheme, the tier 1 and tier 2 is mandatory and is fixed by law. You cannot increase your contribution. But the good news is that the tier 3, which is the personal pension scheme, you can actually decide how much you will contribute. You can even do more than one scheme. You can do 2, you can do 3, and you can decide. So the tier 3 is available for you to do that. I know your association is doing, you have a scheme that you're doing on the tier 3. You as an individual can do that. The only important thing is that you check at the MPRA website and make sure that whichever company you're going to is licensed and is credible, so that people don't take your money and run away. So you can do that with the tier 3. Yeah.
I'm just adding something small to this before he moves to the next question. So this is how it is. Within the law, at the end of every month, out of your salary, 5% is taken to cover both your tier 1 and tier 2. You contribute 5%. The employer, which overall is government, contributes you contribute 5.5%. Government contributes 13%. Together is 18.5%. Out of this 18.5%, 5% is remitted. 5% is remitted to the tier 2, and the rest goes to tier 1, SNIT. That is the 13.5% to SNIT. SNIT will remit 2.5% to the National Health Insurance Levy. And then they will be left with 11%. The 11%, they hold it till your retirement and pay you your monthly pension from that one. And they'll continue paying you till you die. So even if you hit 100, 120, they have to continue paying you. But from 70 years, they will require you to come and show yourself that you are alive. They validate you every year and continue paying you. Okay.
Yeah, thank you, Madam President. So there was a question on, somebody was asking that his contribution, about 7 months delay in release of contribution of members. Someone was saying that he has checked in about 7 months. In my presentation, I made it clear that that is one of our biggest challenge. Your government is not releasing our monthly contributions regularly. So if you check your text message, you see that we have a gap, as you say, by 7 months. It is something that the union leaders are working on it to try to press government to release the funds, because you know when the funds come, we invest the funds and you get your returns. Now we are lagging behind with 7 months. So it's a major challenge that the union leaders are working, and that is why you find that 7 months of your contribution is not tallying.
And it is not as if we are not doing anything about it. Per the law, when the employer does not pay, there is a, how do we term it? There's a surcharge that is applied. So what we do is that we write as a scheme, we write to the employer, we write to the ministry in charge of pensions and copy immediate employer, which is the health ministry, and let them understand that this month's contribution has delayed. It comes with a penalty of this percentage, and therefore we expect that when they are paying the contribution, they will add the surcharge. And the only entity that can enforce this is the regulator, which is the National Pensions Regulatory Authority. Sometimes we feel they are not doing their best when it comes to these delayed payments of contributions, because they know the implications. But like it's been said, we are working on it, and we are hoping that all those monies will be paid promptly so that it can be invested and you get the returns. So projection on returns on investment, we cannot project anything for you at this time. I have shared the last AGM report. Chairman, you have seen it. Share it on your platforms. When you read it, it is in there. You will see all the figures as transpired within the period of the year 2024. The kind of investments that were done, the returns that came in, the real return that you had in the year 2024. Annually, we have our AGMs. And for the past 3 years, we've been having it. So come next year, another AGM will be held. Maybe this time it will not be in Greater Accra. Maybe we'll move to another region so that some of you can also benefit. Usually we ask the facilities to bring health workers to participate in the AGM. And some also join online. Majority join online. So hoping that it moves to your region so that you can also have the opportunity to participate. Thank you.
Yeah, thank you, Madam President. There was a question on, a member said he gets SMS message with a different name. I think that's a very serious thing. and we will take interest. Please kindly come to the stands downstairs. We will take personal interest in that. We'll try to correct it. It's something that should not happen. I'm sure maybe it's a system issue. There was also a member who said he has challenges logging in, and he has tried several times and it's not resolving. That's also an issue that we should be able to resolve it today. If not, we'll take the, so please kindly come to the stands down there. We'll look at it and we'll try to resolve it. And then a member also asked that, can private institutions join the scheme? Yes, why not? This scheme, you can join the scheme. What happened is that every worker contributes to this two-tier pension scheme, the tier 1, tier 2, wherever you work. So we have what we call porting. So maybe that your friend, if he wants to join the health sector scheme, he has to contact us and then we will help him to port. The porting means you move from the scheme he is to our scheme. So it is possible, but you can do that if you contact us. There was also the question about members want to increase their contribution. Still, we've answered that question. That you can do that. That is a tier 3, which you are free to do multiple schemes and then also increase the number of contributions you want to do monthly. And then there was a member who asked that did we get a haircut from government when they did the haircut? Categorically, I'll say no. Our leadership was very, very instrumental. Your president was very, very instrumental. They had engagement with government, and all public sector pension funds did not get any haircut. So our money is safe, and we did not get any haircut. And then there was a question on that I have checked my account, and the money is too small. 5% cannot give you cola. The policy violation. Cola. Yeah. If you follow the presentation, I made it clear that the scheme, the tier 2, is a defined scheme. What you contribute, we invest it, and you get returns. So if you contribute 5 cedis, and your friend contribute 100 cedis, definitely your returns will be on 5 cedis, and his returns will be on 100 cedis. So those are the issues that we have. But as I earlier on said, the tier 3 is there. It's voluntary. You can put anything that you want to put, depending on what outcome you want to have. So let's take advantage of the tier 3, and then we'll be able to increase our lump sum when we retire. I don't know whether maybe GS, and if you can answer some of the questions, and then enterprise.
Okay. Yeah, thank you, Madam President. Somebody wanted to know if he can get access to his money and invest it himself. It's not possible. Like my boss said, this is regulated by law. There's a statute that backs the contribution. And for that matter, you cannot access the money and invest it. What kind of investment do you think you can do better than the health sector occupational pension scheme that has a sanctioned financial institutions or fund managers that are regulated by law? Okay, the risk involved in you investing your money is very high, okay, as compared to when a scheme that is being managed by law. So as far as pension is concerned, you need to err on the side of caution, and for that matter, the government will not allow you to pick the money and go and invest it yourself. What about if you run lost at your investment? All right, you decide to use the money for men's good, and men's good throws up. So when it comes to pension, government will not give you that discretion for you to just invest the money the way you want. So if you want to do any other form of investment, the law allows that. And you can even invest in tier 3 and things like that. So this is what I can say as far as that is concerned.
Somebody wanted to know whether some family litigating
And when, after they resolve it, yes, their money is in the accounts. So whoever the court will grant the letter of administration can come for it or probe it, depending on whether the person died testate or intestate. Somebody also asked whether it can be used for mortgage. Yes, the law allows that you can use it to buy your primary residence, but it has not been explored. So it's something we are all discussing. For now, I've not seen somebody use it, but the law allows it. I think these are the things that come to mind. What have been the reasons why we are getting relatively high interest rates? It's obvious. Look at the people managing your investments. We are all part of it, and so it's prudence. That is what I will say. Suggestions to use the regional secretariats and for us to pay rent is beyond me within the board. That one, Madam President, may want to answer.
And I also wanted to know whether the money is invested individually or is pooled. Yes, it's a collective investment. So we pool all the contributions and it is invested in the respective asset classes. And then whatever accrues thereof as dividends is disbursed onto the individual contributions. Thank you, sir.
There was a question that said, what happens to your contributions if you travel out of the country? So to answer that, I think during Mr. Gates's presentation, he mentioned the grounds in which you can fulfill before you can access your Tier 2 contributions. First one was mandatory retirement age of 60, voluntary retirement age at age 55, death, total incapacity, or permanent immigration. Permanent immigration, however, is for our expatriates. So what happens to your contribution? Should you travel out of the country, your monthly contribution is going to halt because controller is no longer going to be paying you. However, your contribution is still invested. So individual returns will still be growing on your accounts. However, the contribution itself stops, but the individual returns will still grow till you fulfill the grounds that boss mentioned, and then you can come and take your Tier 2 contributions.
Yeah,
yes,
so
if you are 60, you can come for it.
Yeah, so if you visit our website, the AGM, we held our AGM recently. All the reports are there, the returns are there, you can get all the information there. So try and visit our website. We also make sure that this presentation is given to your leadership, especially how to log into your account. It's very, very important that we check our account, especially the beneficiary. I'm sure most of you, if you want to ask now, who are your beneficiaries? Most of us don't know. You can simply use your mobile phone to update, to change your beneficiary and update it, and also check regularly your pension so that you don't retire and regret. We want you to retire with a smile. So let's take interest in our pension and we'll retire with a smile. Thank you very much, Madam President.
So we have come to the end of this session, and I want to thank you all so much for being cooperative with us. And a special thanks to Mr. Gaten Adangabe, Member Trustee of the Health Sector Occupational Pension Scheme, and ETA Officer. Please mention your name.
Jackson Ibrahim.
Jackson Ibrahim, for taking us through the presentation on Tier 2 pension scheme of the health sector. Please, let's put our hands together for them. We are still continuing with the presentations, and we'll have our own in-house. Gating, please come for a group photo. The next presentation will be from Access Pension, that is the scheme administrator for our GINMA fund, and they are going to take the stage now.
Sorry? You have it on the drive. No, my laptop. Why you can't get it? I asked him to stop it. I did not realize.
So the next presentation is going to be on our GINMA fund, what you know as Nurses Fund, and it's the same as the GINMA fund. It is not registered as a Tier 3 scheme for reasons best known to us, but we model it as a typical Tier 3 scheme. So we'll listen to the presentations, and after that, we will take your questions. Please introduce yourself. Bridget, where are you? Why are you there? Come up. So we have two representatives from Access Pension who are going to do this presentation for us. We have Mr. Ernest Atiman, who is always with us at our board meetings, and we have Madame Bridget Corte, who is also most of the time with us. Please, let's welcome them with a round of applause.
Good evening to you all, and thank you very much for the time you have given us to share insights on your GRNMA fund. So in our presentation, we will take you through where we have come from as a fund. We'll look at how your fund is structured, the trustees and service providers who are constantly working for you. We'll look at the financial data, fund statistics, and then we'll also talk about how you can access your fund information. Now, let me start by congratulating all of us for 20 years of having this fund. I think February 2005, I think we clap for ourselves. 20 good years of this fund. We started in February 2005. So last February we were 20 years, and I think we have made much progress with this fund. And let me state that in 2015, we decided to change the structure of our fund by bringing on board certain service providers who can help us professionally manage the fund. And from 2015 June up to date, that is September 2025, your fund has grown by 3,420%. I think we deserve some tap on our back. We have done very well as a fund. And if you had invested or if you had funds in the fund from 2015, you would have generated about 436% in returns. And that is also something worth mentioning. Now, in 2015, after the restructuring, certain institutions were brought on board to handle your funds. So we have Access Pension being the fund administrator, we have Republic Bank being the fund custodian, we have Data Bank, Cal Assets, and then Black Stars, who are your fund managers. Now, in the previous presentation, he highlighted the role of all these parties. And so I will not bore you much with that, but we serve the same purpose, just like the way you have it in your health sector occupational pension scheme. Now, our contribution has gone through various changes over the years. We started off with 2.5 Ghana cedis as our monthly contributions, 2 cedis, 50 pesos from 2005 to 2013. In 2014, we moved to 20 cedis up to 2017. From 2018 to 2023, we increased to 50 cedis. And I think during that time, there were lots of calls from members to be able to vary their contributions, such that members will have the opportunity to determine how much they want to contribute into the fund. So currently, that has been done. So between 2024 to date, we have varied contributions, ranging from 50 cedis to 600 Ghana cedis. Now, on the table on my left, you will see how the breakdown is done. I think most of us are still within the 50 cedi bracket, and we encourage as many of us to take advantage of this opportunity to increase our contribution, especially now that it is tied to how much loan you can access from the association. we encourage you to increase it. Then on my right, or the right side of the slide, I've also shown the top 7 member holdings. So when we take all of your holdings, the people who come up in terms of member balance, I've tried to show their balances here. And I just want to highlight something with regards to this. When you look at their contribution amounts and investment gains, you would realize that the investment gains is more than how much they have contributed into the fund. And this is because your fund is at the stage where the investment income we get contributes more to the growth of the fund than how much you contribute on a monthly basis. And that is how a typical fund cycle is supposed to be. As the fund grows, your gains contribute more than how much you put into the fund. Now, this is how your fund is structured, just like your health sector occupational pension scheme. We have the board of trustees, you have the custodian, the administrator, and the fund manager. Currently, these are the board members serving on your fund. We have our own president, being the chairperson, Mrs. Perpetua Furiampofo being the chairperson of the board. We have Dr. David Tinkran Chum, the board secretary,